Добрый день, глубоко уважаемые.
Greetings, dearest colleagues. Greetings, dear friends. I am pleased to welcome you at yet another webinar of the Eurasian Arrhythmology Association. Today, the focus of our attention is hypertrophic cardiomyopathy. This disease is definitely, the way I see it, underestimated. The issue definitely has immense clinical significance. And it so happens, at least in our country, in Russia, that hypertrophic cardiomyopathy is kind of believed to be a surgical condition. However, any practicing GP, any practicing cardiologist know full well that phenotypes of this condition are very different. One of the key phenotypes of HCM, which is also definitely heavily underestimated, is sudden cardiac death. This particular problem, as well as other important aspects of hypertrophic cardiomyopathy, will be dealt with today at the webinar of the Eurasian Arrhythmology Association. There will be speakers, renowned cardiologists, experts, and our beloved, dearest colleagues. I am pleased to welcome esteemed colleagues, every single one of you. Today we have Professor William McKenna. I hope you can hear us. He's based in La Coruña these days, Spain. We're very pleased to see you there, to welcome you here this morning. I hope that you're enjoying great weather in La Coruña. Also, here with us we have academician Yuri Belenkov. I believe that he will join us shortly. Dr. NATALIA Sonicheva from Amsterdam. We are pleased to welcome you as well. Good morning, esteemed colleagues. Good morning, Andrei. Thank you very much for responding to our invitation. Well, thank you for extending the invitation in the first place. SVETLANA ALEXANDROVA. She's with us. Yes, I can see you. Okay. Good morning, colleagues. Good morning, Andrei. She represents the R&D Center of Cardiovascular Surgery named after Bakulev. We are tightly in touch for magnetic resonance diagnostics in the most severe patients. This is our long-standing operation. We are happy to see you. ELENA BARANOVA, good morning. Good morning, dearest colleagues. Good morning, Andrei. I'm so happy to see you. I'm particularly happy to see you because you are my teacher, and I am happy that you have found the opportunity to be here with us today, this morning. Elena represents St. Petersburg, the department of St. Petersburg. I am happy to refer to this university as my alma mater. Elena used to be one of my teachers. I'm so happy to see you there this morning. Evgeny Zhulyakov, he represents Moscow State University, our department, arrhythmology and disorders of conductivity. Moscow State University, named after Mikhail Lomonosov. We have Olga Kostoleva here. Good morning, good to see you. Yeah, I've been instructed to disable my video and I'm re-enabling it. Okay, thank you for joining us. She's a PhD in medicine. For years, she's been working with one of the classics of arrhythmology, Professor Vochel, a renowned person in the Soviet Union and Russia these days. The Russian-speaking space knows his classical monograph on continuous cardiostimulation. It's a renowned book that is widely circulated, widely available in the Russian-speaking space, dedicated to working with patients with implanted devices. It was published and republished multiple times. I believe it's over 30 years old now. We're happy to see you today. You'll be talking about subcutaneous ICDs. Olga is from Moscow. Okay, dear colleagues, now the floor goes to the first speaker of the day. And definitely, we hope that Professor William McKenna, that we all know, that definitely, well, his ventricular classification, ventricular rhythm classification, every student in the Russian-speaking space knows it by him, including online space. Professor William McKenna, whose contribution in presenting mechanisms of HCM is hard to exaggerate. Professor, you have the floor today. The topic of his presentation would be hypertrophic cardiomyopathies, natural history, epidemiology data, pathophysiology, and classification. Professor McKenna, the floor is yours.
Thank you. So it's always a pleasure to be in Moscow. It's even better when you're there in the flesh than on Zoom, but this in the current climate we'll have to do. My topic, as mentioned, is really an update on hypertrophic cardiomyopathy, and Andre, it's not moving. Sorry, the slide is not moving. Okay, so it's an update, and Andre asked me to really deal with classification, diagnosis, the epidemiology, and pathophysiology. And I'll straighten the diagnosis. It's important to recognize that incomplete disease expression actually is the majority of patients, not a minority. So I will stray into the genetics, which Natalia will deal with in greater detail. And I'll mention in management very briefly the importance of the family history. This obviously will have a historical component. All of these areas have been worked on for years. This is a stylized survival curve that I published almost 35 years ago. And you can see that, as was mentioned in the introduction, sudden death is very much part of the phenotype. And in that era, you can see in the children, young adolescents, 6% annual mortality and about 2 to 2.5% over the years. And the majority of patients did not reach their 60s and 70s to develop atrial fibrillation and heart failure. And as a credit to many people working in this area, this is the stylized survival curve now. And rather than falling off the curve at different ages, most patients with hypertrophic cardiomyopathy actually survive into their later decades. And we're seeing much more of the atrial fibrillation heart failure component. And this is a credit to many things: early diagnosis, greater recognition, and particularly the ICD, which effectively will prevent you from dying suddenly from an arrhythmia. The classification goes back to 1960s, and the original classification was actually proposed by my professor and mentor, Professor John Goodwin, at the Hammersmith Hospital in London. And at that time, these same conditions, hypertrophic, dilated, and restrictive cardiomyopathy, were diagnosed on and the classification was based on idiopathic. In other words, here is a patient with this phenotype, and we don't know why. And in that era, cardiac disease was hypertension, rheumatic heart disease, ischemic heart disease, valve disease. These were conditions which were recognized to cause sudden death, heart failure in the young and in families, but we didn't know the cause. So the terminology idiopathic or unexplained was introduced. With the recognition of the first gene for hypertrophic in 1990, we no longer are idiopathic, we know the cause. And so the classification, however, we've stuck with it. Why? Because in actual fact, from a clinical standpoint, it's very, very helpful. So there's an American classification which is based on the genetics, but you don't know when you see a patient who comes to your office, it's because of a symptom or a sudden death in the family or an abnormal electrocardiogram. It's a phenotype. It's not a myosin binding protein C that walks through your office door. So we've stuck with the phenotypes. Now, the phenotype of HCM, that can be sarcomeric, which is disease which we're talking about today, but it can be also many other, from amyloid, Fabry's, Noonan syndrome. So these phenotypes need to be characterized, and then part of that, an important part of that, is actually looking at the family, getting detailed family background, and then targeting the genetics, and the improvement in genetic, the ability to sequence and look at the genetics is dramatic. So ideally, you may start off with an HCM, DCM phenotype, but you end up with a disease subtype. The disease subtype we're talking about today is hypertrophic cardiomyopathy caused by sarcomeric disease, disease-causing genes. How do we make the diagnosis? Well, unfortunately, the pathologist still is often the initial person to make a diagnosis. And he or she will rely on the heart weight and the left ventricular wall thickness. Now, those are clearly related to size, and there's some artifact that comes in with death. But the classic feature, which he also is part of it, is the myocyte disarray. So this slide on the left is a myofibrillar stain, and that's the red, and you can see the striations of the sarcomeric contractile proteins. And on the background is the stroma connective tissue, which is white or a blue color. On the right, we see the classic myocyte disarray, disorganization with increased disorganization, surrounding increased areas of loose connective tissue. And you can have up to 40% of the myocardium can show that disorganization. So that, if you're looking at sudden death, that is the substrate for macro reentrant arrhythmias. Obviously very hard to prove because you can't take the heart out, chop it up, quantitate it, and then put it back in. But when we do risk stratification, we're actually making indirect measurements of that disarray, which is the major risk factor in this condition. Clinically, we diagnose it on the basis of an increase in left ventricular wall thickness. It's not explained by the loading conditions. And I'll come back to the loading conditions in terms of hypertension when we look at the epidemiology. But in adults, in practical terms, it's a wall thickness that's greater than or equal to 15 millimeters with any imaging modality. But the main imaging modality we use is echo. It's the simplest, we're most experienced with it, and it's sufficiently accurate. It's beat to beat. In children and small adults, you sometimes will change the criteria to 2 or more standard deviations above the predicted. And sometimes in females, you use one greater than or equal to 13 millimeters. But this has been standard for many years. The screening tool is the electrocardiogram. And clearly here is a young man. He's actually now a physician with an abnormal electrocardiogram. But that T-wave, left ventricular hypertrophy with repolarization changes and T-wave inversion, 1 AVL, and the lateral chest leads. This is abnormal. Is this hypertrophic cardiomyopathy? Could be. Happens to be. Could be dilated cardiomyopathy, could be aortic valve disease. It's not hypertension, and I'll come back to that. This is well beyond what you would see in a young man, and it's well beyond what you would see from long-standing uncontrolled hypertension. This is his echo. He was asymptomatic. His exercise capacity was 80% predicted. He has a left ventricular outflow tract gradient of about 50, and he's got roughly 3 centimeter hypertrophy. Curiously, he's 19. His echo was not very different when he was 14 years old, but he's now he's in his late 20s, early 30s, and his echo, he's scarring and he's losing the dynamic function. This is another electrocardiogram, and this is a fairly classic ECG for someone with apical hypertrophy. And again, the ECG is your screening tool. It's not your diagnostic tool. The imaging is your diagnostic tool. But here, if you look at the deep T-wave inversion in lead V4 and V5, this is someone who is very likely to have hypertrophy predominantly in the distal ventricle. This gets labeled as apical. It's not truly the true apex. It's in the distal ventricle from papillary muscles down. And we see that here in this short axis at mitral valve level, relatively normal. But as you go down, the thickening is increasing. The other imaging modality which has become important is magnetic resonance imaging. And here you see, I don't think this will play, but here you'll see on the top left is end diastole, on top right is end systole. So there's septal hypertrophy with dynamic near total emptying. And then the first short axis cut on the lower left, you can really see the septal hypertrophy. And on the right is the main reason to do magnetic resonance imaging if you don't have, one is if you don't have a good echo window, but the second is to quantitate and to assess the evidence of late gadolinium enhancement. And so we see in the septum, the white is the late gadolinium, and usually that occurs in areas of hypertrophy, and it's been proposed as a marker of risk. That remains to be established, but that's certainly, it is part of the overall assessment of a hypertrophic patient. So what you can see in the yellow, we're talking about sarcomeric disease, but it's quite important in the evaluation of someone with that phenotype to consider some of the other conditions. And certainly when I went to medical school, mitochondrial disease and fatty acid metabolism and glycogen storage, there was almost no point. This was like memorizing a telephone directory because there was nothing you could do with these patients. Now there are therapies for most of these conditions. So it's actually quite important to make a diagnosis of Noonan syndrome or some of the fatty acid metabolisms or Fabry's disease. And this needs to be considered, and time doesn't permit, but a very simple rule is that whenever you have any additional phenotype, cardiological or otherwise, whether it's an accessory pathway, whether it's audiovisual problems, whether it's renal disease, think outside the sarcomere box. It's very likely to be something else. Sarcomere disease affects the heart and the heart only. This is a story that is very close to my heart. So this is a pedigree published by Peter Paré, who was an eminent chest physician in Montreal at the hospital where I trained. And this pedigree was the study by him in the late 1950s. And it was in this family that we found, in collaboration with the Zeidmans, the first gene for hypertrophic cardiomyopathy. And it's due to Peter Paré's work 30 years earlier that this occurred. So this is from northern France to Canada in 1690. And because of the fact that it's Catholic, and so all baptisms, marriages, and deaths are recorded in the church, we were able to get complete record. He was able to get complete records, and we were able to study the family 30 years on. This is again of interest to me in that he was my boss when I left Montreal to go to London. And also this family come from the village where my family come from in Quebec, on the Quebec-Vermont border. And it was referred to as the Quaticook, which is the name of the village curse, because these people all died, these children died suddenly. And I remember playing hockey and having a 12-year-old not come back for practice because he died suddenly. This family resulted in the first gene in beta-myosin heavy chain being identified, and we now know that there are multiple mutations in important protein genes encoding important proteins of the thick and the thin filament. And Natalia is going to go into some detail on that. I show this because it's very important in making the diagnosis. And our concept of disease in 1990 was that you have a gene, and if you have that gene, you have the disease, and you're fully penetrant, and you have complete expression of disease. And that probably we wouldn't have found the gene if there had been significant incomplete expression or non-penetrance. So this is the first myosin mutation, the arginine 403 in the French-Canadian family. There were 50, and two other publications. There were 53 gene-positive individuals. All 53 had an abnormal ECG and an abnormal echo. So there was nobody who was non-penetrant, nobody with incomplete expression. And that, as I said, it was our concept of disease at that time. It didn't take too long, however, as you will see, to recognize that actually that was not the rule. That was not the rule. That was the exception, to have complete expression like that. And here are two other myosin mutations which were published early on. And you see that of the 65 patients who carried the variant, or mutation, 27 had a normal echo, and of those, some of them had a normal ECG. So incomplete disease expression, low penetrance comes in, and even more so when you see our initial experience with troponin I, where the first 96 patients, 58 had a normal echo, and of those, 49 had a normal ECG. So you might say, are you sure that troponin I is actually causing hypertrophic cardiomyopathy when they're all mostly normal? Well, within these families, there was marked heterogeneity. So you could have a grandmother who has very mild 1.2 centimeter ASH. Her daughter has an abnormal electrocardiogram with normal echo, but the 12-year-old has 4 centimeter hypertrophy and needs a transplant. So tremendous heterogeneity within the family. Very importantly, though, of everything that I've shown is you do not die suddenly with a normal echo from troponin I or myosin disease, or C protein for that matter, but not shown. However, you can die suddenly from troponin T disease. And this was our experience of troponin T, and the pedigree on the upper left was published in Heart in collaboration with Professor Michael Davies, who was an eminent pathologist in the UK at the time. And all 4 people who died at the ages shown as their initial presentation. So they were asymptomatic, one was making tea in the kitchen, another was walking to work. They died suddenly as their initial presentation, and the pathologist in this town where they lived looked and said, well, the coronaries are normal, everything seems normal, and he sent the hearts to the great expert. And the great expert, Michael Davis, said, actually, these people have extensive disarray, and the example I showed you with the 40%, which is on the lower right, is from the girl, the 21-year-old. Extensive myocyte disarray, but they don't have left ventricular hypertrophy. The heart rate is normal. And he speculated that this was some form of this is written before the genes, but this is a non-hypertrophic cardiomyopathy, with the disarray being the paramount feature and the greatest risk. What's shown there is the 23-year-old girl, the sister, who's a survivor. That's her echo, which is completely normal, and short axis cuts are normal, but her ECG is not normal. And that clearly, or presumably, is reflecting the disorganized myocardium rather than hypertrophy. Importantly here, message is that you can die suddenly from troponin T disease with a normal echo. I emphasize all of this because I gather that there's a predominant electrophysiological component to this meeting and to the audience. The concept of having a normal echo with abnormal ECG, normal echo, is probably incomplete expression of one of the inherited cardiovascular diseases. Now, we're focusing on sarcomeric hokum today, but the message is exactly the same for desmosomal disease that causes arrhythmogenic right ventricular cardiomyopathy. It's the same for long QT. So when you have an abnormal ECG, or when you've got arrhythmia, be thinking about incomplete expression of one of the inherited conditions. It could be there's inadequate imaging of the apex in particular. It could be in the athletic community. It could be performance or recreational drugs. But think there is something wrong. You should not be attributed to part of the physiological or cardiovascular adaptation in the elite athlete. Whether T-wave inversion on an ECG is acceptable with racial variants, I know that there's been publications in the athletic literature, actually from former fellows, Sanjay Sharma included, where T-wave inversion in V1 to V3 is seen in Afro-Caribbean athletes. Again, I would have a healthy skepticism. An abnormal ECG is an abnormal ECG, and certainly warrants looking carefully at the family and with more detailed imaging. If we switch to the epidemiology, here the standard in all textbooks, the paragraph on epidemiology says hypertrophic cardiomyopathy is 1 in 500 of the population. And that is by and large correct. And that's the work over probably close to 20 years of Dr. Marin, who's done a number of studies looking at different groups, mainly in America, but he's pulled together the world literature as well. If you examine that more carefully, And if you read that, hypertensives with LVH of more than 15 were excluded in 7 of the 8 studies which determine prevalence. And I mentioned at the beginning that you don't see T-wave inversion V4 to V6 and inferior and 1 in AVL in hypertension. Even in long-standing untreated blacks with hypertension, that does not explain that ECG, that ECG is, and in the presence of more than 15 millimeter, that's hypertrophic cardiomyopathy. And you will appreciate that hypertension is common, hypertrophic cardiomyopathy, 1 in 500, is relatively common. So these two things will coexist. In the past, and when these epidemiological studies were done, if you had hypertension, they considered that you couldn't have HOCM, with hypertrophic cardiomyopathy. Well, that's not correct. And if you correct the prevalence, it's about 1 in 300, 1 in 350. Interestingly, some of the epidemiology, the early textbooks say that hypertrophic cardiomyopathy is a disease of young males and older females. That's clearly nonsense at one level, and yet male expression, male recognition of disease much more common in the young female, in the elderly, but you would expect 50-50 in terms of the presence of the mutation. Disease expression may be a function of many other things. The other thing that's quite clear that has changed is that certainly for many years it was said that the disease developed in your childhood, adolescence, and if by your early 20s you didn't have it, you weren't going to get it. And that was expressed in some of the early guidelines. That's actually not correct, and certainly myosin-binding protein C in particular, there's age-related expression coming in over the decades. The other feature that we don't understand, but is probably correct, is it appears to be more common in people of Afro-Caribbean origin than in Caucasians. This is the list of studies. Whoops, excuse me, that's my colleague, Dr. Montserrat. This is the list of studies that have been published, and if you just go, first of all, to the second column, there's 12,000, 4,000, 15,000, 33,000. So these are large studies, and on the far right, you see the numbers of prevalence. So they're all 0.17, 0.17, 0.19. The three, and so they're all more or less 1 in 500, 0.2. The 3 outliers are studies that only looked at the medical records at the time, and they come up with a much lower number. And that actually, it tells you something. It means that this condition is not being diagnosed in the community. One is Olmsted County. I forget where the others are. One is the Veneto region of Italy. So the condition is actually not being, at the time that these studies were performed, the condition was not being diagnosed. And the only studies that picked it up is when you systematically did ECG and echo on a population. The pathophysiology is of interest, and I've put left ventricular outflow tract obstruction at the top of the list, and that's because it's treatable. And and you mentioned in the introduction that this was considered to be a surgical disease, and that's because some of the early interest in Russia was from the surgeons, and you can actually surgically, with a myectomy, remove the offending tissue and relieve the gradient. And now there's other ways with catheter ablation, and perhaps even with drugs, with the new mivacamten, which was published recently. So that's important. The diastolic function, however, is the major problem, and I'll come back to this, but it's frustrating because there is no drug, there's no procedure that significantly improves diastolic function. You can control heart rate to some extent with conventional drugs, particularly beta blockers, and you can get an optimal heart rate for filling, but you're fundamentally not altering the dysfunction of filling. Ischemia and mitral regurgitation are there. The ischemia must be more important than we are able to attribute or to identify, but I'll come back to that. But ischemia and mitral regurgitation should be considered when you have a patient who is symptomatic, particularly on exercise, because these are both issues that can come on with exercise. So if we start with the outflow tract obstruction, this has been an argument that started in the 1960s between two very powerful groups, Eugene Brownmold's group at the National Institute of Health and John Goodwin at Hammersmith in London. And like many arguments, both sides are correct. So this is a simultaneous M-mode echo on the top, and on the bottom, simultaneous is actually the recording of a radionuclide time activity curve. And if you can focus on where it says SSC in the middle, unfortunately my pointer is, I don't think the pointer is going to work. So but it says where it says SSC in the middle, that's SAM septal contact. And if you track up, you see that the anterior leaflet of the mitral valve is hitting the septum. And that is conventionally considered to be the onset of the gradient. If you come back down to the time activity curve, the 100 is when the ventricle is full, and the bottom, the nadir, is when it's empty. And you'll see that probably in this example, 70% of the heart has emptied. So the onset of the gradient is important. The onset of the gradient is very early in systole, when most of the blood hasn't gone, then this is obstruction. But if the blood is totally emptied, you cannot call it obstruction, even though there may be the recording of a gradient. So this is the argument, is the gradient that you record in hypertrophic cardiomyopathy obstruction, or isn't it obstruction? And this is dominated, certainly it's not as big an issue, but this dominated for about 25 years. This is the data from the simultaneous recording of an echo and the time activity curve. And you see what the pressure gradient was on the bottom, on the x-axis, and how much of what volume of the ventricle would remain, what volume of counts from the time activity curve remained in the ventricle. And you see when you have a gradient of 40 or 50, the heart is emptied. 80% of the heart is emptied. 80% of the volume is gone. But if you've got a gradient of 100, less than 50% is emptied. So it totally depends on the magnitude of the gradient. And when I said both sides are correct, in practical terms, this argument has gone away. And in practical terms, largely because I think it's recognized that if you treat somebody with a gradient of more than 50 with either alcohol ablation, surgery, or perhaps now the new drug mavacamten, you basically improve exercise capacity and symptoms. Importantly, and again, if you consider the focus that obstruction has had, if you look at bad hypertrophic cardiomyopathy in terms of impaired quality of life, exercise capacity, it's not the patients with obstruction. It's the patients with restrictive filling. It's the patients with diastolic dysfunction. This is the good group. And they're good for many reasons. One is because you can manage them, and if you reduce the gradient, you improve exercise capacity and symptoms. Our real problem in this condition is right here. And again, this is the stylized time activity curve from a radionuclide study. NED is end diastole, ES is end systole, IR is the isovolumic relaxation period, and PFR is the peak filling rate. So on the left is a normal, and if you look at right at the bottom, that isovolumic relaxation time is short, and it's usually on the time activity curve, it's about 30 milliseconds. If you look on the right from a patient with hypertrophic cardiomyopathy, well, not a patient, it's a stylized. So as an example, the isovolumic relaxation time goes out to sometimes 90 milliseconds, and the peak filling rate falls right off. So this is stylized, this is real. The top is a normal, the bottom is from a patient, and you see the time to peak filling, the peak is prolonged, the peak filling rate is lower, and importantly, the bottom part of the curve is prolonged, the isovolumic relaxation. And part of the argument is this impaired early relaxation, or is it actually prolonged inefficient contraction? And of course, it's slightly theoretical. The heart, if it's completely emptied, will maintains the pressure, so that volume at the bottom is the same. And you could say, well, some would say that's prolonged inefficient contraction. Others would say it's impaired early relaxation. The bottom line is There's no drug or procedure that improves that particular aspect. The diastole is a problem, and on the left, this is a sophisticated analysis performed by Bacharach and Green, working with Bob Bono at the NIH in the late 80s. And you see these, again, time activity curves, and you see if you look at the systolic part, there's relative homogeneity, and if you look at the diastolic part, relative homogeneity in a normal. This is looking at quadrants, so not all the same. If you look on the right from a patient with hypertrophic cardiomyopathy, the systolic component is actually very similar to normal, but the diastolic component is all over the place. And if you look at a hypertrophic heart, it empties, and normally it empties, heart empties and fills. Hypertrophic goes, it empties, and then it fills irregularly. And that irregular filling, if you do any kind of pixel by pixel analysis, you have very irregular filling of, and that's very, it's actually relatively easy to measure. We don't measure it because there's nothing you can do about it at present, but that's a key component of major problem with this condition. The other two areas to mention around pathophysiology, one is ischemia. And if you look, most patients with hypertrophic cardiomyopathy will have on the resting ECG 1.5 millimeter ST segment depression in lateral leads. And on exercise, it may, you may get 2 millimeter. And so clearly, if you're looking at coronary disease, this is abnormal. In hypertrophic cardiomyopathy, you look at the coronaries in the young person, they're normal. We've been unable to show that this is prognostically important. And overall, it's been very difficult to measure ischemia. And I suspect if you had a continuous measurement of troponins or CPKs, but we don't have, in practical terms, we don't have a good measure of ischemia in this condition, though there's a lot of evidence to suggest that it's important. In an individual patient, however, when you have someone with exercise limitation, it's always worth looking at two things. One is mitral regurgitation, because you get abnormalities of the mitral valve that occur that will change with exercise, with increased heart rate. And the other is ischemia. And this is a 22-year-old girl who has, for argument's sake, 5 to 6 millimeter ST segment depression on exercise, and her blood pressure does not go up. Her blood pressure, systolic blood pressure on exercise is 100, and it stays the same. And if you control and experience, not of this particular patient, but of others, if you control heart rate, because it's usually heart rate related, if you control heart rate, you usually can reduce this and improve exercise. So it's numerically, it doesn't come out in the guidelines because it's a small number of patients who have this. But when you have an individual patient who has exercise limitation that's not explained, it's useful often to do exercise echo to listen for the mitral regurg, and actually to look carefully at the Holter on the exercise test to look for the ST segment changes. I'm going beyond my mandate here in that I'm not supposed to talk about management, and I won't, but I want to just highlight the very top. This is a slide from a review by our group. Perry Elliott was the first author. And if you look at the very top of this, it says hypertrophic cardiomyopathy. Again, important to exclude other conditions, and the list is much longer than this. And again, any additional phenotype, think outside the box, think outside of sarcomeric disease. And the other point I wanted to make here is if you go into the far left, others will consider symptoms and management and risk, but if you go into the far left, the family screening is very important. And the family screening is particularly important in relation to looking for this. Yep. Okay, I'm on my last slide here. Do you want me to stop, or should I? This is my last slide. So this is just the family history, looking for associated phenotypes. And in summary, there's the summary. Thank you.
Please go ahead. The final slide.
Well, it's there. It's just that's the final slide. So just in summary, incomplete expression is
Thank you. That will be enough. Thank you so much.
Thank you.
Esteemed colleagues, unfortunately, our time is strictly limited. And as you can see, there have been certain challenges, technical challenges. There was some problem with the sound, but I assure you, when the English and Russian transcript are prepared in today's webinar, these glitches with the sound will be removed. Cordial gratitude to you, Professor McKenna. Thank you for participating in our webinar. Most likely there's a number of questions that would have come your way, but we simply don't have the time for that. So please, dear colleagues, I would like to announce the next presentation. It is my pleasure to introduce Academician Belenkov. Okay, he's not there. Oh, in that case, Professor McKenna, we can use the, can you hear me? Yes.
Yes.
Professor McKenna, if we may, we do have a certain time window because one of them is running late. So you can have a few more minutes.
So, well, just
allow questions and answers from the colleagues. So,
I'm happy to take questions. A very simple message is summarized that
Natalia, any questions?
so it's true, and I guess if you have a longer perspective of a couple of decades, there's a much greater awareness in the physician community about this condition, not just in cardiologists, but in the general community, general practitioners. So it has improved. I personally, the tendency is to go to the most expensive and difficult to access tests. The ECG, if you were on a desert island and you had one test, the ECG, because a normal ECG, you see that in less than 5% of patients with hypertrophic cardiomyopathy. And if the ECG is normal and you carry a mutation, the risk of a complication, other than, and I highlighted, the troponin T, but the risk of a complication is very, very low. So the greater awareness of the ECG and the concept that most patients who carry disease-causing genes are probably not going to die suddenly, and they're probably not going to have complete expression of disease. But recognizing abnormal ECGs in the context of a family, and within the context of a family, it can be very variable. So the troponin I, if you recognize mom has T-wave inversion 1 in AVL, you say, oh, she's probably all right, we won't worry about her. What is that? Is that mild dilated cardiomyopathy? Is it hypertrophic? What is it? Because that has bearing on the family. And didn't present it, but we have examples where somebody ignores that in mother and then the 17-year-old dies suddenly. So it's greater awareness. The answer to your question is much greater awareness and use of a simple test that we all know how to interpret, 12-lead ECG. Yeah, thank you.
Thank you very much indeed. Thank you very much, Professor. Esteemed colleagues, we have Natalia Sonicheva speaking next. You have the floor. We will need to shuffle the schedule around a bit. I believe your presentation will be interesting to many. This is the significance of clinical implication of genetic testing of HCM patients to predict their outcomes. The floor is yours. You can hear me, right? Natalia? What's up with the sound? Now, I apologize, I forgot to unmute the mic. There was supposed to be some, yes, you can hear me and you should see my slides. Can you? Yes, we can. Okay, it's online. Good afternoon, esteemed colleagues. Thank you very much once again for the invitation to participate in this wonderful symposium. It's a great honor for me to be among top experts on the panel here, top experts for HCM. The previous reporter, previous lecturer, the guru of the topic, Professor McKenna. It's a pleasure to be a co-speaker alongside such marvelous experts. I will elaborate on his presentation, well, as it happens. I'll be talking about clinical and prognostic significance of diagnostics and its practical significance for cardiologists, which is especially important because it's a disease, a condition that is occurring quite often. As Professor McKenna had mentioned, the prevalence is 1 to 500, 1 to 300 people, depending on the estimates that go by. What's happening around conventional cardiologists? How often do you see patients with cardiomyopathy? Well, should be 3 to 4 times a month. And they say they see only 5 to 6 such patients a year. And this is related to the fact that it's incomplete penetrance, age-dependent penetrance, because it often happens that a patient that had been admitted to us or that came to us does not present with HCM, but they already carry the mutation, the genetic mutation. Under diagnostics, which also needs to be improved, will be also another topic of my presentation. Autosome dominant type of inheritance of this disease means that it's carried through generations, and the risk of passing it from parents to children is nearing 50%. It is dangerous because of the risk of sudden death, which is 3 times higher than the overall population. Another important point, clinical manifestations are completely heterogeneous. Could be asymptomatic carriers up to very severe clinical symptoms. This heterogeneity of clinical manifestations causes us to think about more precise and more careful, more thorough diagnostics of these patients. HCM is a sarcomere disease. Sarcomere is the heart's engine. You can see it here on top of the slide. It's thick and thin filaments. The thick filament is represented with myosin, 2 heads, and a long tail. The thin filament on top is a complex of troponins: actin, troponin C, troponin I, troponin T, and tropomyosin. Tropomyosin is a regulator. It blocks the section actively that is further connected to the myosin head. In course of contraction, cardiac contraction, the calcium ions that are released from the reticulum under neuromediation during the action potential, the calcium ions block troponin C. And this blockage opens the opportunity for tropomyosin to displace. It changes its location. Then the myosin binding C protein, the myosin head is linked to the active actin section. It regulates and it induces cross-bridging and power stroke. This cross bridges and the energy that is emitted when the myosin head is joined with the actin, it contributes to the motion of actin. Below you see the normal sarcomere activity. There is the movement to M zone and cardiac contraction happens. And normally we have norm on the left. Efficient relaxation in normal contractility of the myosin head. After there's been a movement of sarcomere, there is a relaxation, and the relaxation stage, ATP molecule is formed until the next contraction, until the calcium leaves the sarcoplasmatic reticulum. What happens when mutations come into effect? The mutation cause the active myosin heads that form the cross-bridging activity. There are much more of those, many more of those, and there is hypercontractility of myocardium that is entailed. Afterwards, there is disorder of relaxation, ATP production. There's a disorder of relaxation. So hypercontractility and relaxation disorder are parts of this diastolic dysfunction that Professor McKenna mentioned today earlier. This is the slide provided to me by Professor McKenna that vividly illustrates what sarcomere dysfunction is about. Left-hand side, there's a physiology that I've already talked about. Right-hand side, this is a rowing process. Rowing when all the rowers are supposed to be coordinated, when the power stroke must be equal on all of them. These are sarcomeres, essentially, the thin filaments and actin fibers and the thick myosin filaments. When this process breaks down, the rowing function is impaired. A shorter or stronger stroke on one rower than the other. It's the same as this array of sarcomeres. Pathophysiology, I won't stop on that because Professor McKenna did elaborate on this point. This array of sarcomere or disorganization, this is dynamic obstruction of the left ventricle. Basically all the symptoms that these processes contribute to. What I wish to emphasize in my presentation, prior to the hypertrophic stage, at the time when there is subclinical disarray of sarcomere, it's very important to catch the disease at that stage, because in that case we can prevent severe life-threatening complications, including sudden death through fibrosis or because of fibrosis. And the patients should be followed up, especially in the light of the emergence of new progressive therapies. Detection of diseases due to the subclinical course at this stage is very complicated, and genetics can help in that, in earlier diagnosis. Etiology of HCM, it was also mentioned by the previous speaker. We should emphasize that HCM is not an exclusion disease as it has been believed for years. This is a sarcomere disease. In 60% of cases, there are mutations that are responsible for HCM, and they are exactly there in the genes encoding the sarcomere proteins. Mostly these are heavy chain myosin mutations, protein C binding myosin. In many cases, these mutations occur, but also it's actin proteins and other sarcomere proteins, regulatory proteins. Currently, there are over 90 genes and 2,000 mutations that are known that are seen in HCM. However, other causes should not be discarded. Some of them, they're genetic, of a different origin, different genesis, or non-genetic, that can also contribute to HCM. They're believed to be phencopies of HCM. Phencopies include amyloidosis, 1/4, 25% of phencopies is amyloidosis. Now, amyloidosis is important to diagnose because there is a therapy that can treat this life-threatening severe condition. Besides amyloidosis, there are accumulation disease, retinopathies, sarcoidosis, malformations, endocrine, neuromuscular disorders that need to be taken into account. And there's a 25 to 30% that's left, which is a quite high percentage. When we're doing diagnosis, we cannot find these mutations. They're not phenocopies of HCM. New genes, intron variants, CNV. So why is that percentage so high? Since genetics is a blooming field these days, these are the new genes which are yet to be discovered, which have not been discovered to date. New genes keep getting discovered every day. There is the homologous domain, the new gene that was discovered by the Health and Code database, Health and Code laboratory in 2014. It is well studied now. This is indeed the gene that causes HCM. Beside that, it could be intron variants, which are not always visible during interpretation for genetic diagnostic of HCM. For example, the myosin binding C protein, the intron variants play a high role in the development of hypertrophic cardiomyopathy. Interpretation of CNV is very important. So it's important to see how many genes are in the panel in the assay, because most labs only study the main genes, which indeed are the most frequent causes of HCM, but not the only cause. That's 11 genes we're talking. However, apart from these 11 main genes, there are up to 90 genes that can cause hypertrophic cardiomyopathy. And their interpretation, appropriate interpretation in a specialized laboratory, is very important. A few words about the new genes that causes actinium polymerase, and that causes HCM in 1 to 2% of cases. It is often seen in myosin light chains, actin, troponin C. So its occurrence is roughly the same, although, well, FHOD3 was not previously discovered. Phenotype is similar to other sarcomere mutations. The left-hand side above, there are survival curves of patients with HCM, which are seen in case of such genes. It's also seen that red is males, although the blue is females. Women live longer with a more favorable course than men. And below there's a graph for diagnosis. Men who are diagnosed more often and more frequently. Of course, we need to carry out further research to understand functionally how these genes operate. And I believe this is going to be done in the future. This is done as we speak. This is being done as we speak. So genetics, what for? Why should we be using it? Especially when we are diagnosing HCM. Well, it's important to diagnose correctly. It's phenocopies that require a totally different way of management. The timing of diagnosis is particularly important. Early initiation of treatment, again, this can help. Again, genetics can help there. And the time of complication and prognosis. It's very difficult to determine by the clinical manifestation the accurate prognosis, because you know that the clinical picture can change. If we're talking about the family history, it's not always complete. Sometimes it's difficult to diagnose based on that. Also, there are de novo mutations sometimes. It's particularly genetics that can help. Given the accumulated data, it can give a long-term prognosis for many years to come. We can give a lifelong prognosis in some cases, thanks to the accumulated data. The family data, family screening is important. Familial screening, as Professor McKenna has said, it's critical because the carriers can be detected very early. Preclinically, it's important to catch these cases to prevent severe complications. It helps manage the patients. Also, familial screening helps in case of high risk of sudden cardiac death in relatives. There was a girl that came for a consult to me. It was referred at the age of 13. Her brother died of sudden cardiac death at the age of 19. He was not studied for cardiovascular diseases, no echo KG, no history of echo KG, although it should have been done because his mother had HCM and she died 3 months after her son, aged 49. The septum thickness was around 30 millimeters. The sister, the boy's aunt, also had HCM. The big question is, what do we do to the 13-year-old girl that presented for a consult? So how should we manage her? Should we install the cardioverter device for primary prevention? This is the autopsy of the 19-year-old boy. You see that there is hypertrophy of the septum, of the intraventricular septum. This is the mother's autopsy. Also very pronounced hypertrophy with disarray syndrome well manifested below. So very severe HCM clinical picture. The aunt was also diagnosed with HCM many years ago. The genetic workup showed a mutation, a structural mutation, frameshift FS mutation, K600FS in MYBPC gene, BPC3 gene, myosin binding protein C. This mutation was also confirmed by autopsy in the 19-year-old brother post factum. 9 families with this mutation have been studied, 6 sudden cardiac deaths, 4 stroke deaths, 1 heart transplant. So indeed, this mutation comes with an unfavorable course of prognosis. The same workup showed that the girl is free of this disease. She did not have the mutation, a 13-year-old girl. So the cardioverter was not necessary. So quoting Professor McKenna, if you treat a patient with familiar cardiomyopathy, you don't just treat a single patient, but the whole family. And it's very important to detect the carriers of the mutation among this family. Long-term follow-up is very important. Correlation of genotype and phenotype as per the outcome of the disease. There are many registries that shed light on that, but the only massive significant registry that assessed 24,000 patient years, it was the SHARE registry that was completed in 2017 and published in 2018. SHARE is the biggest HCM registry to date. 12 expert centers, more than 50 years of follow-up. Major countries around the world. Almost 60 years duration, 4.6 thousand patients, mostly probates that participated in the registry. 6% of patients with sudden cardiac death, 20% AF as a complication, 22% heart failure. And the conclusion was drawn that sudden cardiac death is 3 times more often occurring in HCM patients compared to general population. AF, women have a 30% lower risk to develop atrial fibrillation and the same risk to develop heart failure. Young age and sarcomere mutations equal unfavorable prognosis, unfavorable course of the disease of HCM in a patient. Younger patients aged 20 to 29, the risk of sudden death was 4 times higher than the overall population. One more conclusion: if the onset of the disease is early, at an early age, then by the age of 60, these patients will have around 80% of complications. I mean, 80% of patients will present with complications. Genetics in SHARE registry, 60% of patients were tested. Virtually half of them presented with sarcomere mutations, sarcomere mutation positive. In 34 patients, there were over 2 mutations. So the more severe progression, more severe course of the disease. And the age of diagnosis was 14 years earlier in patients with sarcomere mutations. Check out the graphs. It shows that all the complications in green, that's a sarcomere plus mutations in the sarcomere gene, sarcomere encoding gene. All the graphs for overall survival, ventricular arrhythmias, heart failure, atrial fibrillation. We see that across the board, patients with sarcomere mutations had a more severe prognosis and higher number of complications. This shows the same in terms of life-threatening arrhythmias, heart transplants in all patients and in patients with positive diagnosis only, as well as patients with mutations of unknown clinical significance. Maybe this unknown is for the time being, because like I said, annually, there's new data coming up as genetics moves forward. And the patients with mutations obviously had a worse prognosis than the patients that were mutation-free. Beta-myosin patients had 1.7 to 3 times higher risk of unfavorable outcome than the MY-BPC patients. An important conclusion to be drawn. The prognosis does not always depend on the gene where the mutation was found. The prognosis often depends on the localization of the mutation in the gene. This graph shows the beta-myosin mutation, one in blue, quite favorable prognosis, a normal course of the disease. Another one, beta-myosin, arginine, glutamine mutation, which is unfavorable. And, Professor McKenna did mention this mutation today. It's very important to accumulate data about every mutation, about its localization, about every gene involved. The Health and Co laboratory, which is a leader in HCM genetics research and hereditary cardiovascular disease research, they have collected the data on more than 200,000 individuals with hereditary CV diseases and HCM. HCM is the main component in the CVDs. 76,000 evaluated scientific articles by this laboratory, 88,000 families, more than 200,000 individuals. So it's very important to summarize and to accumulate this information. One trial briefly, the impact of the mutation on the prognosis of the disease. Almost 3,000 patients enrolled, sarcomere genes, beta-myosin missense variants. I'm not going to scare you with the number of these mutations. I'll just say that there's quite a lot. There's quite many of them. Probably I have scared you by now. So anyway, this is the survival graph that is built based on these individual mutations. It shows that survival curves are different depending on the variant of the gene affected. This is one of the variants in the head of the beta-myosin myosin head. As I mentioned, the head of the beta-myosin is important when forming connection with the actin and contractility. The converter region mutation, 24 of them have been described, 143 families studied, 470 patients, 158 cardiovascular deaths. That's a very severe variant. It's a very unfavorable variant. This is a 38-year-old woman with HCM that developed severe diastolic dysfunction that warranted heart transplant. Heart transplant at the age of 38. This is her brother, same mutation. However, the phenotype is completely different. This is a dilational dilational cardiomyopathy, DCM. The non-compacted myocardium, you see it on ventriculography, that also had to be transplanted also at the age of 38. And this is a combined phenotype of dilational cardiomyopathy with intact myocardium. So same family, 3 different phenotypes: hypertrophic, dilational, and non-compacted. This is how the manifestations can be different in one and the same mutation in different people. So the 9-year-old girl, insignificant hypertrophy at this point, but this is her echo 3 years on with pronounced hypertrophy. We see the pronounced movement of the valve and regurgitation. The gradient is quite high in this girl. Unfavorable prognosis at the age of 17. So cardioverter might have to be implemented for primary prevention. This prognosis can be determined by the mutations in the same gene. So check this out, the same gene, but a different prognosis depending on the localization. This orange, the red, the converter region, the green, the converter region I've been referring to, and the blue is all other missense mutations in beta-myosin gene. So the prognosis is very different. We can anticipate, according to the diagnosis, it will be earlier for girls in the converter regions with converter region mutations. And the survival will also depend on the age at diagnosis. The earlier the diagnosis comes, the better the prognosis will be. Completing my presentation, can we determine prognosis by each mutation, or is it still a miracle? Indeed we can, dear colleagues, we can do that. However, we need to collect as much data as possible on families, probands, mutation, gene phenotypes, family histories, genealogy. So we need to collect this data and properly interpret it. Proper interpretation is paramount. It should be done in specialized laboratories that know how to work with this data. It is this data that will help stratify the risk, make the prognosis for age and sex. This can be done these days, as you've seen from my presentation. Familial screening will help detect patients as early as possible and prevent the onset of life-threatening complications. Early diagnosis is very important to initiate the modifying therapy to prevent disease progression, especially in these conditions when new modulating drugs are emerging that will affect the function of myocardium. These pharmaceuticals are already available. They are soon to be registered. It's very important to determine as early as possible, to identify these patients as early as possible. We're working in this direction, not just in Europe, but also in Russia. In 2017, we have created the League on Cardiogenetics, National League for Cardiogenetics. The most recent live Congress that we've been able to hold, many participants of today's symposium were part of that event, were attending that event. We continue the development of cardiogenetics in Russia, even online. Current tendency is to shift our cooperation online. We continue to work on the forum, on the symposium. The first cardiogenetic forum was held the day before yesterday, where we're considering clinical cases, tough clinical cases with CVDs, with HCM and others. Every month we will hold this. So this forum is going to become a monthly event. So please feel free to go to our website, submit your interesting clinical cases. We'll be able to consider them and help if we can. Thank you so much for your attention. Thank you very much, Natalia, for your wonderful presentation. I'm amazed. This possibility of genetics are truly amazing when determining the prognosis. However, if I may, Andrei, I have a question to Natalia here. And this question is as follows. Can you hear us? Well, I can hear you, Andrei. I can hear Elena as well. Right, so today in the studio we have some sound challenges. Thank you very much, Natalia. Today is a tough day. See, it's Friday in Moscow. It's a tough day. And this has affected the teamwork, the technical teamwork here in Moscow that were impeccable before. So now we're approaching lunchtime and still we are unable to focus properly because, well, the technical side, technical component suffers today. Professionalism is an important thing of what we do. So once again, thank you so much, Natalia. Can I ask a question? Just no, I'm sorry. As a host, I would like to continue with today's webinar. I have one question. So there's been amazing information, a vast array of genetic data. It's just I'm scared that the colleagues will see us. So there are dozens of views or thousands of views in the Eurasian Association format. Can you imagine what the colleagues in Saratov or Yekaterinburg will see, this genetic stuff that you've presented? What are they going to do with this vast array of data, with this diversity, with this heterogeneity of genetic anomalies in every clinical case? So when we see a patient with HCM, well, we know today's diagnostic criteria. If, for example, we have a patient with AH, arterial hypertension, and there is the 13 millimeter hypertrophy of the left ventricle, and there is a familial history of HCM. I mean, one of the relatives was sick with that. Most likely, we need to establish the diagnosis of HCM. We need to set this diagnosis. So how do we act? You as a league representative, I know that Professor Zateshikov's contribution was significant, this independent association largely. So could you please tell me, how are doctors supposed to act in Russia, any region remote from Russia? Well, Moscow is a separate situation, right? So let's be honest with that. So what would you recommend for genetic workup possibilities? Well, thank you. It's a very valid and appropriate question. If a doctor believes the condition in question to be HCM or potential HCM, of course, proper interpretation of ECG and echo is necessary to consider whether it is actually or it could potentially be the case of HCM. Familial history, definitely a point to consider. Genetic workup. However, as I've mentioned, the genetic workup is best done at specialized laboratories with the relevant expertise and experience of working with these data sets, because there's quite few labs of that nature, and very few in Russia, although we continue to develop this domain, although, well, for the time being, that there are not so many such labs. So referring to a specialized lab. Okay, can you be more specific? Where to? Who do? Okay, you can come to our league, to your website. Yes, feel free to refer to my website or write me a personal email. So, dear colleagues, there will be a link accompanying this webinar to the National Cardiogenetic League. This is an actual recommendation for action. Website or email, yes. I have a question to Professor McKenna. William, could you please tell us this perennial dilemma when a practicing clinician sees hypertrophy of left ventricle myocardium, say with familial history of HCM, what do they do in this case? What is the next move? So do they turn these patients away, say go to the geneticists, and predominantly the genetic plan becomes the main one? Or as a clinician, that doctor continues managing this patient, and the genetic workup, no matter what they are, even the most adverse prognostically, are no longer of his concern. I mean the clinical approach, the clinical stereotype. So how does it happen? How does it click in your colleagues' brains? In Spain or in Qatar that you used to work, or in London? Could you elaborate on that? Did you get my question?
I did. I heard bits of it with bits of Russian thrown in. The patient, the family is actually the cardiologists, and obviously, if you have some developmental abnormality in a neonate or a syndrome in a neonate and a young child, clearly the geneticists have greater expertise. The expertise in managing hypertrophic or dilated or arrhythmogenic cardiomyopathy is actually with the physician, the cardiologist. And the key part of that is evaluate, which we do, treat symptoms, evaluate risk, and do the family history to identify individuals at risk. And when you have uncertainties or when there's young children, other generations, then getting a gene test is valuable for several reasons. One, prognostically, but secondarily for cascade screening in the family. And that's something depends a little bit on your genetic colleagues and the relationships with them. But in general, that's better done with genetic counselor and cardiology supervision of the tests, because in the end, it's interpreting the ECG and the echo in the family of the individuals who are at risk. Where you get the genetic testing done, there are different labs, and Natalia is obviously has been working with Health and Code in Spain, which is a high quality lab. There are other labs, I'm sure, in Russia, but I think in the end, the cardiologists are better at taking that report and interpreting it in the context of the family. But that obviously will differ in different centers. There are some centers, for instance, I'm aware of centers in America where you basically have within the cardiac department people who are trained, fully trained in genetics and cardiology. That is a luxury that most people don't have. But most groups now in certainly European countries have individuals who have at least experience of inherited cardiac disease clinics. In the UK, there's government action about 10 years ago. They agreed under pressure because of continued sudden deaths in young people, they agreed to establish inherited clinics in 15 regions of the country with criteria and including that in the training program of cardiologists. Excuse me. So I would stick with the cardiologist and get genetic testing done as a routine within this context of these conditions.
Thank you. Thank you, esteemed Professor McKenna, for your answer to my question. I understand that the situation is indeed heterogeneous, which is what I wanted to emphasize. These days, the pathways for decision-making could be completely different. And any doctor, any local doctor, sitting in the region somewhere with the patient suspect or with suspected HCM, the cardiologist is the key player in this patient's destiny. And the competence of this cardiology, of his decisiveness, his or her decisiveness, will determine the further course of life of the patient. To a large extent, I'm convinced of that. Elena, esteemed Elena, could you please tell me, you work at the premises of a powerful clinical center, the Almazov Center in St. Petersburg. So your traditions, your center's tradition, your colleagues' tradition in these circumstances is the perennial balance, the suspicion of HCM and genetic workup, clinics and genetics, clinicians versus genetics. What is the emphasis in your center, according to your experience? Esteemed Andrei, the question is very important. It's completely essential. And I believe that the priority rests with the clinicians, because it's only the clinicians that can assess both the familial history, they can evaluate the familial history, the HCM, whether it was raging or dormant in the family, and the phenotype of the specific individual at hand. I was particularly amazed by Natalia's presentation. Genetics does help. However, it's only an extra tool. It's an auxiliary tool. And I've seen that Natalia cooperates with our Kostereva's laboratory of the National Medical Research Center, our medical research center. And we also work with this department. with the geneticists. And when there is such a possibility, we also run genetic workup. Particularly this case I'm going to report in my presentation, it requires profound genetic workup, although this family is with a favorable course of the disease, so to speak. On the other hand, phenotypically, younger members of the family I'm going to present, they had early onset changes, something that Natalia elaborated on in her presentation. If the phenotype hits early, by the age of 60, the changes will be much more severe. So if I may, I'll ask Natalia a question. I have tons of questions, but I'll only ask one. Hypertrophic cardiomyopathy. Its flow can be different for various phenotypic variants. Esteemed Professor McKenna also mentioned the apical, the medial ventricle, and the hypertrophy preliminarily of the upper part of the intraventricular septum with obstruction. So is there genetic mutations behind these options, behind these variants that bring about this phenotype? Well, the most frequently occurring phenotype where obstruction and hypertrophy of intraventricular septum comes from the medial basal section. Various mutations in the multiple genes can contribute to that. The apical phenotype specifically, yes, there are particular proteins or genes encoding specific proteins whose mutation can active filament actin and a series of other proteins that can entail this apical phenotype. Well, it's not frequently seen, but there are indeed certain variants of genes that are typical for this type of HCM. I appreciate your answer, Andrei. If I may, I'll proceed with my slides as a continuation of our discussion. Definitely, Elena, if I may, I'll just briefly summarize of the discussion that we've just had. Of course, definitely. Thank you. Well, I would like to emphasize for our colleagues, for our current or future audience, that the three main points have been just made. That volens nolens will come with us in our clinical work. The first is a very weighted, argumented, and a rigid focus, a stringent focus on the necessity of detailed genetic workup. And the Russian sound is gone for a specific patient. As you have seen, Dr. Sonicheva there, she provided points to support her position for detailed genetic workup. The second milestone opinion, the way I see it, and I would like to again emphasize it for you, is what we have just heard from Professor Baranova, from Elena here. The clinician and their mindset will be determinant in selecting the strategy for patient's examination and the strategy for clinical management, in which case genetics will sort of be auxiliary, or will sort of be in the background, including for the determination of the prognosis. Genetics will serve for that. And the third opinion that was voiced by our dear Professor McKenna was about the position that in one person we can get both competent judgments on the clinical side, the main phenotype, the predominant phenotype of the disease, and the genetic aspects. So this will come in one head, in one person. It's possibly the vector of tomorrow, where a single expert, a proper clinician, a trained clinician will also get profound training in genetic aspects. So embodied in a single person. At some point in our bright future, we'll have that. So I see the image of the new cardiologist that will successfully help patients with HCM. So I'll allow myself the luxury to speculate as a host on these 3 points. So whether I'm right or wrong, we will try to see which point gained more weight following each next presentation. Elena, the floor is yours. It's my pleasure to give you the floor. Thank you, Andre. I would like to thank you and every entity that took part in arranging this forum for this opportunity to exchange opinions on this challenging condition, HCM. I was listening to Professor McKenna's lecture. I just wanted to throw in a small remark respectfully. Among those pathophysiological changes that are typical for hypertrophic cardiomyopathy, together with obstruction, diastolic dysfunction, myocardial ischemia, and diastolic dysfunction, there's also arrhythmias. Arrhythmias also play a significant role in the pathophysiology of a specific patient. My points will be on AF and therapy for these patients. Atrial fibrillation is known. Most frequently, up to 25% of patients with HCM have atrial fibrillation, and they present with a higher stroke risk. I would like you to meet one of the patients of my own. This is her actual pictures, and she allowed to make this picture and to use it in my presentations as necessary. Now, currently, this patient is aged 83. As you can see, she's very lean. I would also like to say that she's a smart, intellectual woman that I first met 21 years ago when she was aged 62. She presented to our clinic for a consult because of her arterial hypertension, second grade. The figures were quite low, arterial pressure 160/90, and she said she has never had higher blood pressure than that. So we see the grade 2 AH. However, please have a look at this shot here, at this EKG phenomenon that was registered at the age of 67. Unfortunately, the 62, the EKG at the age of 62 is missing, but it's the same as 5 years on at the age of 67. Have a look at the gigantic R peak in the V4 lead. Its amplitude is 7 centimeters, 70 millimeters. In the same lead and V5 lead, the very profound negative T down peaks up to 58 millimeters deep in V4, several dozens millimeters. The sum of this amplitude is 58 millimeters in this patient. So having seen this EKG for the first time back then, well, we were mesmerized, we were baffled by that, and when we asked the patient about the EKG that she presented with before, she said, no, it's only been happening recently. But the patient was hospitalized for 3 times over the recent years, suspected of MI, without any pain in the chest, without any manifestations of heart failure. And 3 times this MI diagnosis was shut down. And we first believed that it could be hypertrophic cardiomyopathy. The hypertension degree was really not correlating to this colossal hypertrophy. Indeed, the left ventricle mass index was 180 grams per square meter, and the apical segment was thickened. The medial part of the interventricular septum was as thick as 14-16 millimeters, without outflow obstruction in LV and normal ejection fraction. So proceeding from the most recent recommendations on HCM, our patient presented with this condition, no doubt. If we were to categorize the phenotype, he was predominantly apical and medial parts of the interventricular septum. And then it was, as it was completely justly mentioned by Natalia during today's symposium, we asked our patient the question about the familial history. And she said that her mother was alive. She was 91 at the time. And she said that she could bring her mother for a checkup. This is the EKG of the mother, 91 years old. She died 2 years afterwards. At the time, in 2007, she was age 91. I've highlighted for you on the right-hand side that her EKG is very similar to that of our patient. The same high R peak in V4 lead and the same profound depression of the T point. Same stuff phenotypically, intraventricular septum, 24 in the medial third, and the intact ejection fraction without outflow obstruction in the LV. So this is what we see here briefly, this genetic tree of our patient. The mother is already deceased. Our patient is alive. Her daughter was also followed up, and her granddaughter. They're completely healthy, the two individuals. However, her son and her daughter present with no hypertrophy of left ventricle, but there is Parkinson-White syndrome and the phenomenon of Wolff-Parkinson-White. So how did events develop further? We prescribed follow-up for our patient. We prescribed anti-hypertension therapy, perindopril plus indapamide, within the scope of the clinical trial. Then she had supraventricular extrasystole. Small doses of beta blockers were prescribed. At the age of 73, 10 years ago, there were ventricular rhythm disorders. And not just that, significant extrasystole and brief paroxysms of ventricular tachycardia. That warranted the prescription of amiodarone in the supporting dose, 200 milligrams loading dose and 100 milligrams supporting. Then 4 years on, she felt the pain in the sternum that was believed to be potentially of angina nature. Coronary angiography presented with no pathology. However, Holter monitoring identified ventricular extrasystole, an episode of inconsistent ventricular tachycardia, which again brought her back to amiodarone therapy that she's receiving to date. 1 year on, her son sent her to Freiburg, to Germany, the Freiburg clinic, where HCM was confirmed, and also the hypertension disease. High heart MRI was carried out. Ejection fraction was at 56%, intact. Hypertrophy of medial and apical heart segments was confirmed. No signs of LV outflow obstruction. Beta blockers was approved, as well as with antiarrhythmics, ACE inhibitors, and other angiotensin therapy. This was happening until the age of 80, when our patient for the first time presented with paroxysmal atrial fibrillation. So 80 years AF, what do we have on echo KG at that time? The thickness of IVS reached 25 millimeters, no obstruction. The myocardial mass index, MMI, 206 grams per square meter. 47 millimeter, the left ventricle size, and the ejection fraction was also preserved, but with elements of systolic dysfunction. This is our patient's echo with the thickening of intraventricular septum, predominantly in the medial third. So what are the risk factors of AF can occur in a patient with hypertrophic cardiomyopathy? Well, first of all, it's advanced age, senior age, because regardless of HCM or not, 80 years of age is a risk factor for AF. Left ventricle dilation, chronic heart failure, diastolic dysfunction, as well as hereditary predisposition. Now, let's consider the algorithm or the pathway for decision-making in HCM. Well, definitely we identified the pathology. We saw the atrial fibrillation as a complication. Our patient did not present with severe heart failure phenomena. However, regardless of her leanness, she's somewhat limited in her movement because of the bilateral osteoarthritis, deforming osteoarthritis of knees. But she does have atrial fibrillation. It presents with symptoms, dyspnea, fatigue, and, well, feeling unwell. Anticoagulants and antiarrhythmics. Let's consider the medications that we prescribed. Paroxysms and paroxysmal AF is infrequent, and the amiodarone treatment, which is the recommendation of 2020, amiodarone is recommended to manage patients with AF and HCM. So at the backdrop of amiodarone intake, these paroxysms are infrequent. The symptoms are less pronounced these days. As for anticoagulation therapy, and the recommendations prescribe anticoagulants for these patients with HCM at all times, unless there are contraindications to take them. The central image from the most recent guidelines on HCM says that there is a principle called ABC, the ABC principle, which means that we need to prevent with anticoagulants. B stands for good symptoms control, symptoms management, controlling the sinus rhythm or controlling the ventricular contractility frequency. Our patient is on amiodarone with good effect, with good efficacy. And C is concomitant pathology treatment. In the case of our patient, it's decent control of AH, because treating diastolic dysfunction, well, unfortunately, we cannot do that these days, or at this point. These are the scores of in the guidelines, validated score points, chart, chest to VASC, and Hasbled. So having done the math for our patients, her stroke risk is 6, it's very high, but the hemorrhage risk is as low as 1 point. Her age is over 65, that's the only risk factor. So anticoagulants for our patients with HCM and asymmetric, unobstructed, asymmetrical HCM without LV outflow obstruction. Why it's stage 3? Because there's atrial fibrillation. Anticoagulants are definitely indicated. However, in our diagnosis, we will, for our patients with atrial fibrillation, we will highlight all the risk factors: ERA, symptom score, CHET2, DS2, VASC, and Hasbled. In that case, we will have a clear algorithm, a clear pathway on what to do for such patient in the future. I'd like to emphasize that this patient with long-standing hypertension, she does have CKD, and the creatinine creatinine clearance for Cockcroft-Gault formula, which is the one we're supposed to use, was only 47 milliliters per minute. So this formula is supposed to be used by us when assessing the grade of CKD. Her age of 83 is also, well, not too beneficial for the renal function, definitely. The correlation between HCM and embolism at the backdrop of atrial fibrillation is this. Fibrillation in HCM patients results in marked increase of thromboembolic events. This slide shows survival curves of patients that are free of MI, no MI history, if they have atrial fibrillation and don't, and not. Now, left-hand side, AF with HCM, right-hand side without. So, dear colleagues, it is clear that the presence of HCM is a standalone, is an independent risk factor for ischemic stroke, and it's a direct threat to the survival of our patients. Proceeding from that, several years ago, there's been an analysis of various risk factors of stroke. Professor Inoue suggested including HCM as an independent risk factor for stroke into the CHED-VASc score. However, in 2019, Young and Lip have offered the modification of CHED-VASc scale to include HCM into the C criteria, even for patients without chronic heart failure. I also believe this to be a simple and justified amendment to the scale, because the presence of HCM comes with a larger number of thromboembolism, and it justifies lifelong anticoagulation therapy in these patients. So this is the modified CHED-VASc score that you know full well. But if the patient presents with HCM, which is highlighted there, and definitely atrial fibrillation, then that patient, even without documented diastolic or systolic dysfunction, that's 1 point on CHED-VASc score for that patient with HCM alone. And our patient has not 1 but 6 points on that scale. The recent guidelines show the green box, class 1, grade 1 for men, score 2+, 3+ for women. Anticoagulants are recommended. However, if it's a patient with hypertrophic cardiomyopathy, then even a lower score, say 1, is enough for us to prescribe anticoagulants. 2018 guidelines were, the 2018 article was published. It's important to use novel peroral anticoagulants. And it says that there is limited data on the use of NOACs, but the NOACs can be used to prevent stroke and embolism in such patients. However, as time goes by, in 2 years, or 2 years on, there have been studies published and meta-analysis data emerged that at the backdrop of NOACs use, the patients with HCM present with lower numbers of stroke, lower overall mortality, and intracranial hemorrhage. Another major meta-analysis showcased here, patients on NOACs, black bars, the black bars are for them. Vitamin K antagonists, VKAs, are the grayer bars. And in this case, the NOACs in all research, they have shown lower frequency of thromboembolisms. Major bleeds are less frequent compared to VKAs. and the overall mortality is several times lower than among patients that were receiving warfarin or other vitamin K antagonists. So these days, virtually every guideline out there says that the presence of hypertrophic cardiomyopathy and fibrillation means that all patients with that are supposed to be on anticoagulation therapy. Most guidelines also say that there is no preference or no specification or VKAs or NOACs. However, this is the data that was obtained several years earlier. I hope that the meta-analyses that I've presented will at least give us a clearer picture, more confidence that the NOACs are usable. So which one do we go for? There is a publication of 2019, Dr. De Caterina, that differentiate the use of NOACs depending on the individual features of the patient. Unfortunately, this publication says nothing about HCM. However, if this is a recurrent ischemic stroke, or if we want to go for pharmaceutical with higher efficiency to prevent both ways of both types of stroke, hemorrhagic or ischemic stroke, then the publication's authors give us the only option, the dabigatran 150 twice daily. If this is impossible, other alternatives can be considered. So what is the justification they offer to prove that to support their point? The direct analysis or head-to-head analysis of various NOACs is missing. All these pharmaceuticals were compared to warfarin only in RCTs. However, what is still visible here, the dabigatran is the only NOAC in the dose of 150 milligrams twice daily. It was superior to warfarin to reduce the number of ischemic strokes. For intracranial hemorrhages or ICH, all NOACs are superior to warfarin, but the dabigatran's favor is more favorable in that respect, 72% compared to low percentages in other NOACs. Another problem that bothers us in senior patients, especially such as ours, is high risk of GI bleeds and ventricular bleeds. In this case, the experts do not recommend to use rivaroxaban, and only epixaban or the dabigatran from the ones available in Russia are left in reduced dose, the dabigatran 110 twice daily. So again, what is the justification for that? The randomized controlled trials show us that, unfortunately, on rivaroxaban, the number of GI bleeds, the count of GI bleeds, was significantly higher than on warfarin. However, for other anticoagulants, there was no difference. Major bleeds on the dabigatran and the epixaban contributed to lower bleeds. Another problem that our patient has is moderate renal impairment, 47 creatinine clearance. And in this case, again, all three types of NOACs can be used. The most recent guidelines show us or have this table to offer us with this creatinine clearance 47. We can use the dabigatran in both dosages, 150 or 110, but we're supposed to down titrate to reduce, to lower the dose in case of higher bleed risk. And 80 years plus rivaroxaban should be used in reduced dose, 50 milligrams, and epixaban in case of indications, also reduced dose. Our patient weighs less than 60 kilos. She only weighs 50 kilograms. These are the indications that require the reduction of the dose. As you can see, the bigatran, because of her age, is 110. Reduced dose rivaroxaban could have been used in the reduced dose of 15, and apixaban was 2.5 milligrams twice daily. However, when we looked at the data of RCTs, we noticed this fact. A very limited number of patients were receiving the reduced dose in these trials. And unfortunately, there is no separate analysis to show that these patients have a benefit of reduced dose of rivaroxaban and apixaban, their superiority over warfarin. And the reduced dose for the bigatran 110 has been studied. And there is proof that shows non-inferiority to warfarin on the bigatran 110. The efficiency is the same as in warfarin, but the number of bleeds is lower with the bigatran. Hypertrophy studies, the RELY study, a comparison of the bigatran and warfarin showed that the bigatran in both dosages, 150 and 110, patients with LVH, strokes, and systemic embolism was occurring less frequently than at the backdrop of warfarin use. One more point, low body weight, 50 and slightly less than 50 even kilograms. There's a small section in the practical guidelines that is dedicated to this in European Society of Cardiologists. The recent guidelines say that the bigatran was researched post hoc in patients with low body weight under 50 kilos. Its efficiency and safety was comparable to the main cohort. However, this low body weight, this low BMI can be a predictor to bleeding. Our patient's situation is different. She's just lean. She's not underweight. She has been like that for a long time. I mean, this weight has been preserved or has been maintained for a long period of time. Because of the time limit, I cannot dwell on issues of low weight on the apixaban, but again, we need to remember that the weight under 60 kilos on apixaban is the indication to reduce the dose. Apixaban is less studied in patients with low body weight. So the bigatran has advantages over warfarin: 24% lower risk of ischemic stroke, 20% lower risk of cardiovascular death, 72% reduction of intracranial hemorrhage, and the possibility to neutralize, possibility to use a neutralizing agent in case of emergency. So we use a bigatran for our patient in the reduced dose because she's 80 years. That's a requirement to reduce the dose. She's receiving this pharmaceutical to date. No significant side events to point out. Thank you very much for your attention, dear colleagues. Thank you very much, esteemed Elena, for your presentation. Any questions, dear colleagues, to Elena? Natalia, I believe you might have a few. Thank you, Elena, for the interesting talk. I enjoyed the information that you presented, especially the familial history that you presented. However, I'm thinking about the son of this patient who does not present with the HCM phenotype to date, but possibly he needs to be examined early on. I believe it makes sense. And possibly her son would be the candidate for genetic diagnostics. So first the mother and then the son according to the variant found in the mother. Yes, we do have the blood of both the mother and the son and the granddaughters, we plan to engage into this with Ala-Kostereva. Besides the Wolff-Parkinson-White syndrome, the son had 2 cases of myocarditis. Myocarditis first happened in France. He was on a business trip, and the second myocarditis, he went for treatment to Almazov Center. No hypertrophy at this point, no HCM, no AH in this son. However, we are constantly monitoring this family, thoroughly monitoring. Thank you for your question. Thank you for your question and the interest in my presentation. Dear colleagues, any further questions to Elena?
Yeah, possible to ask a question from here?
Of course.
May I ask a question?
Please go ahead. Sure.
So you started on, so the genetics, this family is fascinating in that to have this level of onset at that age and those voltages and the short PR, that's typical of a storage disease, but doesn't fit perfectly. But that could be AMP kinase, it could be Danon, except the Danon, you should have depressed LV function. And then clearly there's the transmission female to female to male to female. So it's very, whatever the gene is, it's of interest and it's probably publishable. So I would start with the mother or the older generation to find the gene. I think what Natalia said. The other thing that you pointed out that the arrhythmia is an important part of, if you will, the pathophysiology. That at one level that's true because it means sudden death is, I don't know if you call sudden death an AF pathophysiology, but they're very important. And to have the AF, how do you monitor a hypertroph for atrial fibrillation? We would do annual Holter. And when you start to see 3 beats and 5 beats and 10 beats of supraventricular arrhythmia, you need to come in with the you can come in with amiodarone, and if you can abolish, but if you can't abolish and show that you've abolished the arrhythmia, then you have to anticoagulate, but it's early anticoagulation because it's a disaster when a young person has a stroke. It's a disaster when anybody has a stroke, but particularly a young person. So the AF management is very important. And just one throwaway comment is that unexplained syncope, no one has published a really good paper on syncope and hypertrophic cardiomyopathy. We did with continuous monitoring. Most of the episodes are actually undetected paroxysmal atrial fibrillation with uncontrolled heart rate. So it's very important in the whole management of the condition.
Andre, if I may, I'll respond to Professor McKenna's comment. Andre? Yes. Yes, please go ahead.
I agree. I mean, in principle, totally agree. Would you start with anticoagulants, or would you start with trying to suppress the arrhythmia with something like amiodarone? Good. Very nice. One last comment. There's a tendency to try and keep cardioverting patients and keeping them in sinus rhythm because of, quote, the importance of atrial contribution to stroke volume. By the time a hypertroph goes into atrial fibrillation, stroke atrial contribution disappeared decades before. The fourth heart sound usually is a mark of an atria contracting a flow into a stiff ventricle. That ends, and the next phase is a palpable apex beat, which is an atrial pressure phenomenon that you feel. From that point on, stroke volume contribution from the atria is negligible. So as soon as you start getting a lot of atrial fibrillation, cardioverting is a waste of time. Just control the rate in sinus rhythm. Sorry, in atrial fibrillation with beta blockers, verapamil, even digoxin. But it's a very important management issue, the anticoagulant and then the control of heart rate. And it's when they flip from AF back and forth from sinus to AF that the problems happen.
Thank you very much for your comment, Professor McKenna. Thank you very much.
Well, thank you. Beautiful, beautiful family. Study it.
Спасибо большое, глубоко уважаемые коллеги.
Thank you, esteemed colleagues. I realize that we're touching upon a new
Проблемы это фибрилляция.
important clinical paradigm, atrial fibrillation in patients with hypertrophic cardiomyopathy. I have one brief question. Елена,
Благодарю вас за доклад.
so once again,
Я
thank
знаю,
you for
что
your
вы
talk.
вынуждены будете нас
I know
покинуть.
that you will have to leave us a bit later. And before you do, a quick question before you go.
Для пациентов с
According to your
гипертрофической
clinical experience, patients with HCM and AF,
хотя бы какая-то теоретическая
is there
возможность
a theoretical possibility
клинического применения
for clinical administration of
антиаритмического класса?
first antiarrhythmic class 1 antiarrhythmics?
Уважаемый Андрей Вячеславович,
Well, dear Andrei, the recommendations of the guidelines say that the class 1 antiarrhythmics are contraindicated to patients with hypertrophic cardiomyopathy. That's a contraindication. So at our clinic, we maintain this point of view.
И вопрос к профессору Маккенна.
Okay, and a question to Professor McKenna.
Что профессор Маккенна имел
Professor, I know that
отношение
you've had
в нашей российской медицине.
direct relationship to Russian. You've made a direct contribution to our medicine, Soviet and then Russian. Well, let's call it Kremlin medicine. And you must know very well the class 1 antiarrhythmics that were used back in the day. Historically, they were developed in the Soviet Union, etazine particularly.
Что любая гипертрофия
Today we understand that any hypertrophy basically buries class 1. And patients with AF, nonetheless, patients as if with hypertrophy with less than 14 millimeters, they are theoretically given a chance, only theoretically. They have a shot at the use of class 1 antiarrhythmics, only purely theoretically. Proceeding from your expertise, including the empirical, historical experience for the Kremlin medicine, I believe that back in the day there were no stringent limitations to the clinical use of pharmaceuticals such as etazine. Can you comment from where we stand today, a patient with AF and HCM, is there any chance to use class 1 antiarrhythmics in such a patient?
I guess we're in a sort of zone of bias and experience, but no trials. If you go back to the 1980s, certainly in Europe and America, diazepyramide prior to amiodarone was the most utilized antiarrhythmic for both ventricular and supraventricular arrhythmias, and it was used in hypertrophic cardiomyopathy to reduce the gradient because of its negative inotropic effect, which is what effectively killed it as an antiarrhythmic drug, which was useful in hypertrophic cardiomyopathy, but not in heart failure. And there's decent registry data from Mark, I'm blanking his name, but from New York, and good publications and registry data showing safety using disopyramide in, I think it was 400 milligrams daily, but in the absence of any renal impairment and with normal electrolytes and no diuretics. And I think some of the proarrhythmic effects occurred because of electrolyte imbalance and renal problems. That said, with the advent of amiodarone, we stopped using class 1 agents, and I know that there are anecdotal examples, and I know in our clinic, we had people stable on amiodarone. Somebody came in, a new doctor came in, stopped the amiodarone because he said it was dangerous, and put somebody on flecainide, and sudden death a month and a half later. It's all anecdotal, but I would avoid, if at all possible, a class 1 in hypertrophic cardiomyopathy, I think. But that may not be correct, and it's usually the class 1s, the proarrhythmic effect is linked to electrolyte imbalance and renal impairment and the use of other drugs. So if you're just using class 1, I don't know is the quick answer, but I would tend to try and use amiodarone first, and I wouldn't use a class 1. But that's
Спасибо большое. Спасибо большое, глубоко уважаемые коллеги.
Thank you so much, dear colleagues.
Тем из нас, кто будет смотреть эту
Those of us who will
в будущем, я
watch
очень
this,
настоятельно
the
рекомендую
future audience,
внимание на
I recommend,
четкую и ясную позицию.
please have a look and consider the clear stance voiced by Professor Baranova, by Professor McKenna, with respect to class 1 of antiarrhythmic therapy in patients with hypertrophic cardiomyopathy that comes with atrial fibrillation.
Спасибо большое еще раз, коллеги.
Thank
Я
you
с
so much
большим
again, dear
удовольствием
colleagues. It is my utmost pleasure to give the floor to the next speaker.
Светлана Александровна.
Svetlana Alexandrova. She will talk about the role and place of CT and MRI of myocardium in patients with HCM. The floor is yours, Svetlana. Good afternoon, dear colleagues. Thank you very much, Andrei, for the invitation to participate in this symposium. As a radiologist diagnostician, I would like to highlight the options of X-ray, of radiology, means CMR, for example, on besides the classical visualization imaging techniques. Magnetic resonance imaging is taking a more prominent place day by day in cardiology and cardiosurgery because there is no ionizing radiation, and there is a possibility to study both the functional parameters of the heart, morphological parameters of the heart, structure, myocardial perfusion, as well as viability of myocardium. This can all be done in one go in a patient. Contemporary visual diagnostics in cardiology involves multiple methodologies. However, I would like to highlight the upsides and downsides of the main ways of imaging, CT and MRI. As you can see from the slide, the temporal resolution is the highest in MRI compared with CT. However, a spatial resolution is best for computer tomography. As for the anatomy and function research or examination of myocardium and the heart as a whole, these two methods come more or less hand in hand, diagnosing cardiovascular pathology. One of the significant disadvantages or downsides of MRI is potential ionizing radiation. Right, so typical features of HCM, a lot has been said today about the diagnostics, DDX. Classical is the massive hypertrophy of myocardium without apparent reasons. Often it's the obstructions of the outflow of the right portions of the heart, more frequently left ventricle. Also, there is the mediaventricular obstruction, hypertrophy of the intraventricular septum. Diagnostic criteria have been elaborated on by Professor McKenna today. MRI is used to determine that. The same figures are used for ultrasound for echocardio. First of all, is the thickening of the myocardium over 15 millimeters. The correlation between the thickness and the medial wall more than 1.3. The side wall more than 1.3. And the thickening of LV wall more than 2 standard deviations of the anticipated median in the same age group. However, as it was mentioned multiple times today, myocardial hypertrophy markers can be different diseases that imitate HCM. MRI today is the golden standard to assess the morphology of both the functional parameters of the heart, the volumetric parameters of the cardiac cavities, and the structural changes. As opposed to echocardio, the MRI is free of the ultrasound window problem. And we can clearly assess the thickness of myocardium in the left ventricle. We can do it using the segmentary model, measuring myocardial thickness in every segment in at 3 stages, systole and diastole. Thus, we can diagnose any form of HCM. As for computer tomography, same opportunities, same approaches are also available in CT. We have done a research. This year it was published for the role of MRI and CT in surgical correction of this pathology. We've been able to show that there is no statistical significance between the values of hypertrophy as diagnosed by MRI or CT. In clinics where MRI is not available today, but there is multi-spiral MSCT, multi-spiral computer tomography, the same markers of HCM can be detected as it would have been possible with CT. It was also mentioned, various phenotypes of HCM have also been mentioned by now. A vast number of them have been described today. From the focal basal form of diffuse septal form, the C form, which is the most frequently occurring, to patients without hypertrophy of myocardium, but with presence of minor cardiac abnormalities, which are most frequently seen in carriers of HCM gene. Our group of patients features mostly those with diffuse septal form and focal basal form of HCM. Since these phenotypes come with outflow obstruction of the left ventricle, then most frequently it is these patients that are candidates for surgical correction of this myocardial pathology. Also, there's been a few words mentioned today about the SEM syndrome, which is mostly the precursor or the reason for the obstruction of the left ventricle outflow. However, systolic anterior motion syndrome, the pathology itself, apart from the lengthening of the anterior mitral valve, various anatomical features of subvalvular structures can contribute to that. We've modified MRI workup protocol we have appended it with additional planes to have a look at the subvalvular apparatus.
Модифицированной группы пациентов более
We've
частые
seen in a modified group of patients more frequent causes of pathology, hypertrophy of papillary muscles, hypermotility of these muscles, which is related to the structure of these muscles. Is when the basis is dislocated towards the apex and the anterior wall. We've been looking at these features and we saw that our modified workup protocol helps detect the pathologies in papillary muscles and additional chordae in the outflow of the left ventricle. This helps surgeons prepare more thoroughly, prepare the pre-op strategy to manage the patient surgically. In our patient group, besides obstruction, myectomy of the left ventricle or in the right ventricle, patients also get their papillary structures, additional papillary muscles, abnormal chordae removed. These are the ones that can contribute to the obstruction of the LV outflow. Also, various morphological structure types of chordae of the mitral valves has been described. Papillary muscles features are sometimes precipitating not just the outflow obstruction in the left ventricle, but they also contribute to atrial fibrillation development, because longer cusp SEM syndrome worsens the mitral regurgitation in these patients, thereby increasing the risk of atrial fibrillation. Some more benign findings, minor abnormalities of heart development that I mentioned, the crypts, those crypts or crevices in the heart, congenital abnormalities. These minor abnormalities are often seen in healthy volunteers as well as in volunteers with classical HCM. The detection of these abnormalities is important at the pre-op stage in this group of patients. A more sensitive way to detect these anomalies has been made possible by the multi-spiral computer tomography, because it is MSCT, as I mentioned earlier, it has finer cuts, better spatial resolution. These are the statistical changes, numbers, its depth, patients with HCM, hypertrophic cardiomyopathy. Another new method that helps detect the features of remodeling, of blood flow in the left ventricle, and therefore, as I hope, it will help predict various phases of diastolic function, remodeling of the left ventricle. This is the so-called 4D flow phase contrast scan. It is in the diastolic phase when we see the so-called vortex in the left ventricle cavity that affect the intracavital hemodynamics. The use of this sequence, this imaging series, can help us study the features on the outflow, on the LV outflow, and we'll be able to see the extent of obstruction at the outflow and the anatomical features that contribute to the obstruction. So what kind of anatomical substrate results in this LV outflow? Also, currently, MRI is impossible without the contrast enhancement. It is the contrast medium based on gadolinium that gives us various views of the structural changes in the myocardium. So there are classical buildup types: ischemic type of the contrast medium accumulation, where we see the scar or supracardial subendocardial scar with transmural damage of the myocardium, or it's epicardial buildup, which is typical for inflammatory changes in myocardium. Possibly it's intramyocardial buildup in the intraventricular septum, or microvascular obstruction, typical for dilational for DCMP or DCM. There are many works today that compare the markers of long-term buildup, of long-term accumulation of gadolinium. And in this case, HCM is specifically studied in the case of this article. Myocardial fibrosis in HCM can be both diffuse interstitial as well as focal lesions. It will accumulate the contrast agent. The type of late gadolinium enhancement in HCM is most seen in the intraventricular septum and closer to the right ventricle. There can be an endemic focus, or there can be multiple foci. Anterior septum, anterior side wall, as in these two patients here. Definitely MRI, besides detecting fibrotic lesions, can also help calculate in percentage the amount of myocardium that was transformed, the LGE, myocardial LGE in HCM. Late enhancement in myocardium is a prognostic factor for these patients. So the higher percentage of change is observed, fibrotic changes to the myocardium, the narrower the prognosis would be in this category of patients. However, the acting model of risk factors is efficient. Not all patients with high risk can be detected promptly. The lack of conventional risk factors is not always preventing the sudden cardiac death. SCD can still happen in these patients. So the modified protocol has been offered to prognose SCD. It features MRI and the determination of fibrotic changes to the myocardium. It was shown that fibrosis over 15% or myocardium with LGE, late gadolinium enhancement, is the higher risk factor in patients with cardiomyopathy, HCM. Well, definitely these risk factors also include LVEF, aneurysm of the left ventricle apex. I'd like to highlight several clinical cases. This is a male patient, 37 years old. He presented for MRI with AF, suspected HCM. However, we see that there is an enlarged left atrium area, which is indicative for AF, and the HCM signs are not seen. We only see the borderline increase of the myocardium thickness in the left ventricle at the basal level, in the anterior septal segment, to 14 millimeters. However, this entire segment was fibrotic.
миокард
myocardial fibrosis in percentage was quite high. It was calculated at 17%. The patient was submitted for genetic testing. The gene was identified responsible for HCM, a genetic mutation of MYH7. And in this case, the patient was HCM with negative phenotype, genotype positive, phenotype negative, hereditary HCM, AF persisting form. Next clinical case, a 12-year-old boy. As it was mentioned, the onset of HCM normally starts with the age of 20 or around that. But we frequently see younger patients, much younger patients, 12, 14-year-old teenagers with massive hypertrophy of left ventricle. This is LVH in a 12-year-old patient seen on MRI. The patient was suspected for HCM. You see myocardial thickness is immense. It is more than 3 centimeters for the anterior septal, 28 millimeters, 2.8 centimeters for the anterior septal wall. High ejection fraction, low volume of the cavity. However, the contrasting agent showed very small fibrotic changes, 7% of fibrotic modifications. This patient was negative for HCM.
Генетическое тестирование показало
However,
отрицательный
the
результат.
genetic testing was negative. In this case, we have a patient with positive phenotype but negative genetic test.
Еще один пример влияния именно
Another
на
instance of late enhancement, how it affected the management of this patient. This is a 14-year-old boy. This child was referred to study left ventricle, the MRI of LV. We see the 19 millimeter anterior septal wall and the low percentage of changes, 8% of fibrotic lesions. Genetic testing was done. MYBPC3 was identified. It's indicative of HCM. The following diagnosis was established: hypertrophic asymmetrical obstructive cardiomyopathy, positive phenotype, positive genotype, but there were no prerequisites to implant the ICD. Still, he received one. And during 1 year of follow-up, there was not a single case when it actually activated during this 12-month follow-up. Besides diagnostics of HCM and determining the risk factors of SCD, magnetic resonance imaging also provides for DDX opportunities for this condition. It's delayed or late enhancement, late buildup of the gadolinium agent helps assess these athlete's heart, amyloidosis, Fabry disease, or other types of accumulation, pathologic buildup. Another interesting case, a 26-year-old male, a professional hockey player. He's been doing that since the age of 5. Very small, so no complaints, but the Holter monitoring showed some abnormalities. MRI was done. We see the intraseptal segment up to 3 centimeters, 2.3 centimeters. Akinesis, it's not properly contractile, it cannot contract properly. Normal volume of the cavity, high ejection fraction. As you know, this is typical for patients with hypertrophic cardiomyopathy. Increased mass index of the LV. And we also see the crypts. We see the crevices of the myocardium in the anterior septal segment, in the medial level. We know that this is a marker for hypertrophic cardiomyopathy. Definitely, the administration of the contrast agent presented with typical lesions or typical buildup foci, indicative of HCM, especially for the anterior septal segment. It's virtually never seen in patients with athlete's heart. So this patient was diagnosed with plain HCM. T1 mapping, that's a new methodology in MRI these days to look at structural changes in the myocardium. In this case, it's hypertrophic cardiomyopathy patient. Besides T1 mapping, we can also use the contrast media to see the extracellular volume, the ECV, which is mostly indicative of diffuse changes in the myocardium, diffuse fibrosis in the LV myocardium. T1 mapping is also helping us differentiate the diagnosis. It helps with DDX. It helps identify the markers that are risk factors in this category of patients. We see that these patients most often present with elevated T1 compared to the normal healthy group. Native T1 is elevated. There's a small reduction in post-contrast T1 myocardium, which is indicative of fibrotic lesions that we see in LGE. However, these days there are no clear markers for T1 interpretation that would give us any link with risk factors in these patients. However, the use of T2 mapping and the use or studies of myocardial edema as opposed to T1 mapping. T2 mapping is a marker, according to the literature, that contributes to detecting important rhythm disorders in the ventricle, which in its turn can be used as a potential tool for to diagnose SCD. However, T1 mapping, same as LGE, it's a differential diagnostics tool for various phenocopies of HCM. Also, a small clinical case to go with that, a 56-year-old male, dyspnea, even at small physical exercise, minor physical exercise, overall fatigue. He was sent for MRI. Overall weakness, rapid fatigability. He was sent to the MRI. The myocardial morphology studies showed hypertrophy in virtually every segment. We see no edema in the LV myocardium. Patient presented with increased cavity or enlarged cavity of the both left and right ventricles. It shows the restrictive type of remodeling of myocardium. The use of T1 mapping shows us clear, uneven elevation, diffuse elevation of T1 relaxation time, virtually for all the walls in the left ventricle myocardium. We see the T1 time over 1.2 seconds, which is not indicative of HCM. And we see the extracellular volume over 40. It's enlarged. Late gadolinium enhancement confirms our diagnosis, our suspicion that this patient does not have HCM. This patient is suffering from amyloidosis. MRI was first used to, AL criteria, amyloidosis. The MRI helped suspect that, which was further confirmed by biopsy. It was indeed amyloidosis. another patient, different patient, same as a 46-year-old. He came with similar complaints. Myocardium damage was suspected, indicative of amyloidosis. We see minor hypertrophy of the LV myocardium. We also see the enlargement of the left ventricle, the thickening of the walls of the left ventricle, liquid in the pericardium. However, the bicameral position shows us the scripts, which, as I mentioned, is typical for cardiomyopathy. Normal ejection fraction.
Пациентов с гипертрофической кардиомиопатией.
Which is less typical for patients with HCM. T1 mapping helped us detect diffuse changes in the myocardium. However, T1 relaxation time is much smaller than typical for amyloidosis. The T1 was no longer than 1200 milliseconds. Contrast agent was accumulated pretty much across the septum. So the patient was diagnosed with restrictive HCM. One of the new ways of functional studies of motility, future tracking, MRI-FT, it helps with differential diagnosis of athlete's heart, normal myocardium, and hypertrophic cardiomyopathy. Even in patients with, or even in patients without the HCM phenotype at the early stage of the disease. Future tracking can help look into that deeper. It's better suited for patients with HCM. Future tracking can be used both in right ventricle and on the left one. Changes in the right ventricle or deformations of the left ventricle can help us predict diastolic dysfunction in this category of patients, which in its turn helps handle them in the future. It will enable earlier approach for differential diagnostics and proper treatment of these patients. Another new methodology that I hope will become routine soon. This is the diffuse tensor MRI. The TMRI is actively used in neurology. However, to date, we have been trying, or these days, we have been trying to use it in a cardiosurgical clinic. Same as FT, hopefully, it will help predict preclinical stages. So it will help catch preclinical stages of this disease. It will help study the disarray myocardium, which is something that's frequently found in patients with HCM. Fraction anisotropy is one of the criteria in diffuse tensor MRI. It's a more sensitive marker in this category of patients. This fraction anisotropy in some trials is a marker for ventricular arrhythmias, and possibly in the future it will become a predictor for SCD in this category of patients. To conclude my presentation, I'd like to say that MRI is the golden standard to assess both the structure and the function of LV myocardium. LGE is an important component in DDX for myocardial hypertrophy. It can also be used to study the prognosis of this group of patients. T1 and T2 mapping are gaining popularity. They help visualize diffuse changes in the myocardium. Future tracking and diffuse MRI can help analyze this deformation in a non-invasive and quantitative manner for this group of patients with HCM. Thank you so much for your attention.
Спасибо большое, глубоко уважаемая Светлана
Thank
Александровна,
you,
за ваш
dear
доклад.
Svetlana, for your presentation.
Пожалуйста, есть ли какие-либо
Dear
вопросы?
colleagues, any questions you might have to Svetlana for her presentation?
У меня тогда есть вопрос, Светлана
Okay,
Александровна.
I have one then.
Любезная.
Svetlana, could you please tell me?
Проблема фибрилляции при
I realized that the issue of atrial fibrillation
арритмологами ставит
to us as operating arrhythmologists, it poses important goals or important tasks to visualize fibrotic inclusions in the atrial myocardium wall. The HCM, that is the topic of discussion today. Could you contribute your comments when, in actual clinical practice, the gadolinium MRI will actually help us make a valid judgment as to the distribution of myocardium in the atria? It's not patchy fibrosis or lesions fibrosis. When we'll have a chance of layer-by-layer analysis of fibrotic degeneration of myocardium to give us a better way to see the geometry of depolarization waves because of this fibrotic degeneration of myocardium. Thank you, Andrei. Thank you for your question. This is indeed a promising research field. However, myocardium fibrosis these days, especially its fibrosis, yes, it's gadolinium enhancement, intramyocardial, supramyocardial. For the left ventricle, it's not yet possible. This is because of the spatial resolution, limited spatial resolution of MRI, and the fairly thin wall of the myocardium of the left ventricle. I believe that potentially some other methods will help us detect indirectly the LV myocardium function. This is, for instance, the future tracking that's used today to look at diffuse changes in the myocardium structure of the left ventricle. So I'm really having a hard time predicting or trying to predict when we're going to be able to find the buildup of the agent in the left ventricle. If I understood you correctly, all the perceptions of today, Marush, UT1, UT2, UT3 categorization that talk about the quantitative distribution of fibrosis in the myocardium. They are purely theoretical with your technology involved, with reference to any living patient, or it's not really valid. Those tools are not really valid. Am I correct to interpret your statement like that? No, we do see late gadolinium enhancement in the left ventricle, left atrium myocardium. The genesis of this fibrosis is the changes to the myocardium. However, what is causing it to change? What is causing the myocardium to change, the fibrotic in the left atrium? Well, that's it. It's just there. The localization, the dispersion along the walls, along the veins. We can talk about the quantity, but that's all we can do. That's all we can say about the fibrotic changes in the left atrium. Okay, so if I'm correct, I might as well make this point. Fibrosis, HCM, the meaning of MRI is prognostically important. But what about prognostic importance of the degeneration of the atrial myocardium degeneration, fibrotic degeneration? No, it is being studied as we speak. Okay, it is being studied. Okay, dear colleagues, let us proceed. It is my utmost pleasure to give the floor to Yuri Belenkov, professor, academician. He'll be talking about the possibilities and challenges of treating patients with HCM. Thank you very much, esteemed colleagues. Chairman, I apologize for having to shift the presentation. Yes, my microphone is on. You should be able to hear me. How about now?
Да, Катя, я очень извиняюсь, я как раз.
Так. Сейчас вы меня слышите?
So you can hear me now. Yes, I can. Yes, we can.
Слышим, можно.
Можно, да?
Please
Отлично.
go ahead.
Ну что ж, уважаемые коллеги, уважаемый председатель, прежде всего, я должен
Dear
извиниться за
colleagues,
перенос своего
dear
доклада, но вы знаете,
Chairman, sorry to have
коммуникация позволяет переноситься из города в город, находясь в кабинете.
Fortunately,
Единственное условие для
I can be in my office and be in the same in the other city at the same time with the modern
все мы
technology.
сейчас
I'll try
живем
to
в рамках вот этих вот рекомендаций 2020 года
remain
гипертрофической.
within my time limit. Hypertrophic cardiomyopathy, these are the Russian guidelines that we use today.
Устроено, что
Everything
лечение
seems to
болезни
be
гипертрофической
clear and logical.
кардиоваскулярные,
HCM treatment involves pharmacotherapy and the vascular interventions, surgical, non-surgical ways to reduce the hypertrophic IVS, mechanical support for blood circulation,
на
and
самом
heart
деле.
transplantation.
Вот перед
Everything
вами
seems to be nice and easy.
панель
But what do we have
официально
actually?
признанных
This is
генов.
the panel of officially recognized genes of HCM. 16 main ones and
Я еще
90
раз
secondary. So once again, this is the officially recognized genes that contribute to HCM.
Попытки найти прямую корреляцию
At
между
the
типом
same time, the
мутации,
attempts to find direct correlation between the type of mutation, course, and the prognosis of HCM were not completely successful.
вот в этих генах говорит
So it does seem that the changes in these genes suggest poor prognosis. These genes, to a certain extent, tell us that myosin binding C protein can be involved, is this gene. But check out two
мутации.
people. It's two twins.
У них разница
Those
развития
are dizygotic twins. So consider their development history. It's different. So that means that we have to follow the conventional, tried and true.
то, что мы видим.
Well, we treat what we see. We determine it. We determine the type of the course of HCM, and we try to select the treatment fitting it. It could be stable progression. It could be sudden death, atrial fibrillation, progressive disease, and terminal stage. So pharmaceutical therapy is prescribed empirically since there are no major RCTs in this area. The objective of pharmacotherapy is to increase tolerance to physical exercise, reduce the manifestation of symptoms, and prevent the progression of the disease. So what do the guidelines tell us in this case? So there will be a mix of 2014 and 2020 guidelines, because for pharmaceutical therapy there's very few differences there. Non-vasodilating beta blockers are recommended, selecting the maximal tolerable dose, the first line. Verapamil with tolerable dose adjustment is recommended to patients with left ventricle outflow obstruction. I'll come back to this resting and induced point later on. Disopyramid is recommended as an additional therapy with two beta blockers, and if it's possible to use beta blockers, to verapamil. Disopyramid can also be used with adjustment of the dose as monotherapy to improve patients' symptoms with obstructed LV outflow. Beta blockers or verapamil can be considered in children as well, and asymptomatic adults with LV obstruction, outflow obstruction, to reduce the pressure in the left ventricle. A lower grade of evidence, it's low doses of loop diuretics or thiazides. That can be used carefully. Diltiazem and peroral or intravenous beta blockers, vasoconstrictors, that should be considered for patients with severe induced LV outflow obstruction that comes with hypotension and pulmonary edema, but the evidence grade is way lower. So the main challenges here, the patients with LV outflow obstruction should not receive arterial and venous dilators, including nitrates and phosphodiesterase inhibitors. In patients with de novo poorly controlled atrial fibrillation, restoration of sinus rhythm and adequate rhythm control should be considered before we proceed with invasive therapy. Patients with LV outflow obstruction are not recommended to receive digoxin. As one of the options, and I've shown that before, this is the heart failure development. So what do we have here for HF with preserved LVEF over 50%, diastolic heart failure? So for these patients of NYHA functional class 2 to 4 with F over 50% and lack of data about the obstruction of LV outflow, beta blockers, verapamil and diltiazem should be considered to improve the symptoms of heart failure. Low doses of loop and thiazide diuretics should be considered in patients with class 2 to 4 with preserved EF and no obstruction of LV outflow to improve heart failure symptoms. So cautious use of beta blockers, verapamil, diltiazem, or thiazide diuretics. If it's a patient with reduced LVEF and heart failure, so that's a combination of systolic and diastolic heart failure. So ACE inhibitors or ARBs or sartans are line 1. The patient is intolerant to ACE inhibitors. They're considered as first-line treatment or as a combination with beta blockers. Beta blockers can also be considered for these patients in two ways, as first line and as the add-on therapy, as an addition to ACE inhibitors. Small doses of loop and the thiazide diuretics should be considered for the patients of these functional classes 2 to 4 to improve the symptoms and reduce the hospitalization risk for heart failure. For all patients with continuous symptoms. And the video froze.
Смотря на лечение ингибитором АПФ или сортала
Treatment with ACE inhibitors or beta blockers can be considered for patients without LV outflow obstruction and continuous form of atrial fibrillation. So the next clinical variant, pains in the sternum. Beta blockers and calcium antagonists should be considered to improve the symptoms in these patients. Peroral nitrates can also be considered to improve the patients with angina-like pains in the chest, or there is no data to prove the efficiency in case of outflow obstruction. Ranolazine, very ambiguous data there. The Gentry study, 2016, showed that ranolazine for 2 months, dosed 500 to 1,000 milligrams by daily, contributes to significant improvement of angina and heart failure symptoms and the quality of life improvement. Ranolazine in another study, a Restyle HCM study, multi-center placebo-controlled, ranolazine for 5 months did not contribute to significant improvement of physical exercise tolerability. So this pharmaceutical is quite ambiguous. Next form, atrial fibrillation. If there are no contraindications, it's anticoagulation therapy and antiplatelet therapy. So that's basically what the old guidelines said. The guidelines of 2020 are somewhat different. They tell us that we should use contemporary concepts of therapy with no X. So if there are no contraindications, VKAs, the dabigatran or rixaban or apixaban are recommended to all patients in whom persistent, continuous or paroxysmal form of atrial fibrillation has developed. So we're stepping away from the disaggregants and we are switching to direct oral anticoagulants. The use of Has blood risk must be done to prescribe antiplatelet therapy, restoration of sinus rhythm with electric cardioversion or pharmacocardioversion with IV amiodarone should be considered in patients with recent atrial fibrillation. Amiodarone should be considered as a pharmaceutical to control the rhythm or support the sinus rhythm after electric cardioversion. Dynamic follow-up of these patients. So, now we've been talking about various ways of control. It's EKG, transthoracic EKG, 2 to 24 months clinical follow-up, Holter monitoring, heart MRI that was elaborated on in the previous presentation, load testing, and cardiopulmonary testing. So what do we have here? It took us a year in a very interesting direction. This is the use of Movacam 10, the new drug that is inhibiting. It's a new allosteric inhibitor of cardiospecific ATP of myosin. Movacam 10's mechanism of action, it reduces the number of bridges between actin and myosin. So this hypercontraction is reduced, which is indicative for HCM. The Maverick study was a research of patients with non-obstructive HCM. What were the prerequisites to the study? What precipitated the study? Patients with non-obstructive form, they had clinical manifestations quite often. And to treat these patients, the pharmacotherapy with proven efficacy is missing. Through the change of contractility of cardiomyocytes, Movacam 10 can improve the pathophysiological chain of the disease and improve the HCM symptoms. A limited number of patients was studied, 59. There were 2 dosage groups and placebo. Well, first of all, Movacam 10 does not have SAEs. There were 2 times less of those, or 2 times fewer of those than in the placebo group, serious adverse events. This limited number of patients also showed that in 5 patients there was a reversible reduction of LVEF, reduction of geometric mean concentration of NT-proBNP. This was a dose-dependent effect shown here. The NT-proBNP was reduced. So the use of this pharmaceutical was well tolerated in patients with clinical manifestations. Therapy came with a marked reduction of NT-proBNP and troponin I, which these results can be the grounds to run further clinical research, further clinical trials in such patients, assessing such clinical indicators as LVEF to try to determine the optimal dosage. Movacam 10 was also used in another trial, Explorer, and those were the patients with obstructive form of HCM, OHCM, and the number of patients was significantly higher. There were more than 200 patients there. So various dosages were studied compared to placebo. So 2 combined endpoints. One of them is the increase of tolerance to physical exercise. And blood saturation with oxygen and the change of the functional class. What was obtained as a result? In the Movacam 10 group, there was an improvement for both combined endpoints, 1 and 2. Video keeps freezing, apologies. So the mean gradient of the LV outflow was reducing at rest. The gradient was reduced. The Valsalva maneuver, the ejection fraction did not change.
Временное прекращение приема исследований
So for this reason,
снижением фракции выброса было только у 5 пациентов. Дополнительно у 4 пациентов было отмечено снижение фракции выброса на 50, меньше, чем 50%.
Additionally, in 4 patients, the LVEF was reduced by 50% by 30th week of treatment, at the end of treatment. The LVEF was restored to the baseline in 3 patients by 8 weeks of the washout phase. In patient number 4, the LVEF was still markedly reduced. It was because of the complication for ablation for AF. So the pharmaceutical is quite safe. The use of mavacamten in patients with obstructive HCM contributed to better tolerability of physical exercise, reduced manifestation or reduced, less pronounced LVEF outflow obstruction, improvement of NYHA functional class, and better health. So these results show the specific therapy of obstructive HCM. So dear colleagues, I'm speaking very cautiously now, but probably we are witnessing a more or less specific way to treat hypertrophic cardiomyopathy, be that non-obstructive or obstructive forms. So what's in the future? What does the future hold? In the future, we hope for various science, so omic science, that's called epigenetics, something that follows genetics. Proteomics, metabolomics, and transcriptomics. What can it give to us? What can it give us? Well, ultimately, hopefully, we'll be able to create the phenotype of HCM based on these omics science. Probably we'll also be able to determine or to find the determinants of the phenotypes of HCM. As epigenetic studies show, if the major part of the genome is intact, is unchanged, a number of genes that I'm about to mention, they can change the phenotype without serious changes in the genome itself. So chromatin, causal gene mutations, chromatin modifications, long unencoded RNAs, modification DNA, microDNA, environment, trophic and mitotic factors, post-translation modifications, microRNA, and pathogenetic variants.
Микро-РНК фактически это вирусы, это кусочек.
Essentially, these are viruses. This is an active part of RNA, a virus, microRNA, that affects hypertrophy, that enables or knocks out various genes. The fibrosis that was talked about at length by the MRI expert. So they also determine the viability of the cells, electric remodeling, and a whole number of other processes. And even now, even these days, we know a clear correlation between the expression of certain microRNAs and, for example, the extent of myocardium hypertrophy, or say the extent of expression of a certain microRNA and myocardial fibrosis. Moreover, even the integomeres have been developed to microRNAs, which can reduce the zone of myocardial infarction. We can reduce hypertrophy and myocardial fibrosis, which can improve the atrial fibrillation, regulate the lipid exchange. Leon 11 has shown the reduction of 50+ reduction of lipids, biopharmaceutical, which is again antagomere to RNA, reduces the aneurysm, aortic aneurysms, and so on and so forth. So we have a very interesting future ahead of us. Completing my brief presentation, I would like to say thank you for your attention, and just a statement: the evolution is not yet over. Possibly we are at the very early stage of the proper pathogenetic and efficient treatment of hypertrophic cardiomyopathy. Thank you very much for your attention.
Глубоко уважаемый Юрий Никитич, за ваше сообщение.
Esteemed Yuri, thank you for your presentation. Dear colleagues, now would be the time to ask you questions.
Будьте добры, нам картинку.
Could you please give us a bigger picture? Natalia, you seem to have one. Yes, Andrei, I'd like to comment on something rather than ask a question.
Ваш
Thank you,
блестящий
Yuri,
доклад,
for
очень
your wonderful talk. It's been very interesting, especially the last section about proteomics, transcriptomics. I believe that
думаю, может
this
быть,
direction is particularly meaningful. I'm not sure about your opinion. Maybe this section of etiology of HCM, with
пока
25 to
этиология может
30% idiopathic unknown, it could be
играет важнейшую роль и определяет
discovered by proteomics and transcriptomics.
unknown
Hopefully,
гипертрофической
this unknown
кардиомиопатии.
hypertrophic
И еще я
cardiomyopathy
хотела
percentage will be brought down. And one more thing about this mavacamten, Maverick for HCM, Maverick trial. There is a continuation of Explorer trial, which is longer in duration, because what we want to find out is the long-term impact on prognosis, on the course of the disease.
Исследование Explorer длилось только 30 недель.
Explorer only lasted for 30 weeks, but the mean duration of the next phase is the same, is several years. Same group of patients that took part in the original Explorer trial. More than that, the upcoming cardiologist congress in America
15 ноября
next month,
будет очень
2
интересный
weeks from
доклад
now,
по поводу
it will
влияния
feature a very interesting presentation as to mavacamten's impact on MRI and CT
всех коллег
indicators or
информирую, что
parameters.
будет
I'm
интересно.
just informing the colleagues that it might be a nice occasion to save the day, to have a look at how
Спасибо большое.
mavacamten improves the functional indicators as shown by CT or MRI. Yes, Natalia, thank you for your comments. I know that you're an expert in microRNA. 25 to 30% is a lot. Well, 8% even is under-researched. 92% of the genome has been studied. They're the same in pretty much everyone, and only 8%, the remaining 8% that we know that they exist, but we don't really know how they work out. This is the unknown part. For mavacamten, I did mention this pharmaceutical is safe, but these several cases of reduction of LVEF going below 50%, they require further attention. Possibly they should be considered in the future when researching this pharmaceutical. So what kind of ejection fraction would be safe to start with, to proceed with mavacamten? Otherwise, yes, it's really the case when we might have an actual pharmaceutical to treat HCM. Yes, here's hoping that it's going to be that way. Thank you very much for your communication.
Глубоко уважаемый Юрий Никитич, если
Thank you very
позволите,
much.
вопрос касается,
Dear Yuri,
конечно,
I'll ask you a
у
question
пациентов с
about atrial
гипертрофической
fibrillation, if I may.
кардиомиопатией. По сути, кроме кардарона, если говорить о
Besides
медикаментозном,
cardaron, if we were to talk about the pharmaceutical options of management, there's nothing to treat these patients with, right?
в том числе
Your multi-year
намекаю на опыт
experience,
в кардиологическом центре в советское время,
cardiologist center
в эпоху
in the
внедрения
Soviet times,
в частности, препаратов
etazazine introduction, the class 1 antiarrhythmics.
обнадеживающий интерес
Was there any
именно
hope back then?
первой группы.
Was there any interest in group 1 pharmaceuticals, or class 1 pharmaceuticals? With patients with HCM or simply with LV hypertrophy. So historically, has there been any hope? Well, yes, there have been attempts. I cannot say that they have really been successful. Moreover, I can also say that these days for atrial fibrillation, we are trying to step away from class 1 antiarrhythmics. All the contemporary recommendations mostly feature amiodarone and sotalol. It's just I can only hypothesize that the pharmaceuticals that will reduce the pressure gradient, therefore they will reduce the left ventricle or the left atrium. Maybe they will improve the prognosis of these patients. So far, what we have, it's a very challenging form of hypertrophic cardiomyopathy. It's a very difficult disease progression to treat. AF significantly worsens the HCM patient's prognosis. Unfortunately, the answer to your question is no. There was no call. Thank you, Yuri.
Есть время, несмотря на вашу
If you
занятость.
have the time, despite of your busy schedule, we would like you to participate in the discussion of the next
Надеюсь, вы найдете время. Речь идет о
intervention presentation.
сердечной
We're
смерти, в
talking
том
about the prevention of sudden cardiac death, including intervention technologies.
и
There is one
эффективный
important
инструмент в
and
руках тех,
efficient tool
это
wielded
эндокардиальные
by those of us who are working in ORs. It's electrophysiological,
процедуры в стратификации
endocardial
риска ВСС,
electrophysiological
выборе
study.
тактики ведения
Sudden
пациента с
cardiac death analysis, selecting the management tactics.
Евгения Геннадьевича
Evgeny
Жилякова.
Zhilakov will report on that. The floor is yours.
Уважаемые коллеги, вашему вниманию
Thank you.
представляется доклад, посвященный
Colleagues, thank you for the opportunity to talk about this.
гипертрофической кардиомиопатии.
So, patients with HCM and sudden cardiac death. As you know, the course of this disease has several typical scenarios of this. First of all, this is sudden cardiac death. This is how hypertrophic cardiomyopathy was diagnosed first in the 1950s. Scenario 2 and 3, progression of heart failure. Ultimately, it will determine the outcome for the patient. Next scenario is the atrial fibrillation and various changes, gradient progression without outflow obstruction, and atrial fibrillation and stroke. So in a single individual, there could be one, several, or changing series of this phenomena. The key element here would be a risk stratification, the most traumatic scenario, sudden cardiac death. How do we stratify the risk for SCD? The risk stratification today is based on the guidelines. The most recent guidelines published by the Eurasian Arrhythmology Association. It considers the conventional, the major risks of SCD and minor risks. Major ones are arrhythmias, tachycardia, ventricular tachycardia, cardiac arrest due to ventricular fibrillation or ventricular tachycardia, as well as the gray zone, the familial analysis of SCD cases, idiopathic syncope, hypertrophy of LV over 30 millimeters, and unsustainable ventricular tachycardia. Contemporary markers that have emerged quite recently to stratify the SCD risks this is the fibrosis over 15%. That's on top of what I've said before. Abnormal arterial pressure when tested on exercise. The presence of a single strong marker of sudden cardiac death in patients with HCM. Only one significant marker can be the justification for primary prevention of sudden cardiac death. The most efficient way would be to implant an ICD. What is the importance of methods that can help induce ventricular arrhythmias? We're talking about electrophysiological study in HCM patients. What is the role of this? It dates back to 1984 when there was the first publication that appeared for endocardial electrophysiological study in 7 patients with hypertrophic obstructive cardiomyopathy, OHCM. As you can see, all these patients had a certain extent of LV outflow obstruction, and all these patients presented with symptoms.
При проведении протокола эндокардиального электрофизиологического исследования
In the protocol of electrophysiologic study, 6 out of 7 patients, there were various types of arrhythmia. In 4 cases out of 6, it was ventricular fibrillation or tachycardia. In other 2 cases, supraventricular tachycardia. Tachyarrhythmias in patients with HCM can be the reasons for syncope or the mechanism triggering sudden cardiac death. Therefore, the induction of these arrhythmias in patients with symptoms and HCM can help verify clinically significant arrhythmia and can also help select an appropriate certain treatment strategy. Asymptomatic patients, when the ES was performed, when the electrophysiological study was performed, non-sustained rhythm disorders were seen in 4 patients out of 43, in 6 patients out of 43. Professor Koch, back in 1988, concluded that in patients with HCM, the results of ES will be similar, regardless of the presence or no symptoms. Therefore, in the course of the ventricular stimulation protocol, asymptomatic patients with HCM, ventricle tachycardias and ventricular fibrillation is induced in the same proportion. What is the prognostic importance of inductibility or inducibility or non-inducibility of ventricular fibrillation, ventricular tachycardias? The authors of the Chinese group of authors published a trial that showed the following. 1/3 of patients with hypertrophic cardiomyopathy had inducible features. 3 patients refused from ICD, septal myectomy with subsequent non-induction of ventricular tachycardia after surgical treatment was seen in 2 patients. 1 patient, sudden death. Another case, an episode of tachycardia with broad QRS complexes and successful resuscitation. In 1 case, after ICD was implanted, there were appropriate activation of the device. The conclusion, sustained polymorphic ventricular tachycardia or ventricular fibrillation can be induced in 1/3 of patients with HCM. Should these arrhythmias, should these phenomena be non-inducible in an ES, they are associated, or this non-inducibility is associated with favorable prognosis. Further follow-up, higher frequency of ventricular arrhythmias in patients with induced ventricular fibrillation and ventricular tachycardia was low. However, ICD implantation in these patients could have been justified because of the numerous risk factors. And if we're not inducing tachycardia or ventricular fibrillation, there's a high probability that in the future this arrhythmia will not present itself, will not manifest. Next stage of evolution of the perception about the role of ES was to compare invasive and non-invasive methods to stratify SCD risks among HCM patients. In 2002, the research was published. Professor McKenna was the co-author of this paper. The authors showed that inducible VT or VF, ventricular tachycardia, ventricular fibrillation, is low sensitivity and specificity.
не имеет преимуществ в
It
отношении
comes with low specificity and PPA, and it does not have an effect over, it does not have superiority over non-invasive methods. In the future, the 2006 guidelines, the EP testing was grade 2B, 2015 and 2017, both European and American guidelines basically bumped EP study down to grade 3C when stratifying the risk of SCD.
В 2018 году произошел некий
In
ренессанс
2018, there was a bit of a renaissance
физиологического исследования
going back to the ES or EPS
пациентов с гипертрофической
in patients with HCM.
был связан вот с этой
This
публикацией,
renaissance was because of this publication that the Greek team presented. They did a very interesting and a very simple study. 203 patients with HCM received an APS.
Далее. Пациентам имплантировали
Later
кардиоверт
on, the patients received an ICD implant based on the then current AHA recommendations, AHA guidelines, because of the factors that can be detected non-invasively, and in case of VT or VF was induced.
простые конечные
Very simple endpoints: sudden cardiac death and justified activation of the device because of, obviously, ventricular arrhythmias. The authors got very interesting results. Out of 203 patients, 79, which is almost 40% of cases, in 39% of cases, the VT and VF were induced. 20 patients out of 203 reached the primary endpoint, either sudden cardiac death or the justified activation of the device, the ICD. Of them, in 19 cases of these 20, the initial EPS helped induce ventricular tachycardia or ventricular fibrillation, VT or VF. Basically, EPS helped prognose the onset of the primary endpoint in 19 out of 20 patients, whereas other commonly accepted criteria, risk factors by AHA or ESC,
внезапной сердечной
risk
смерти
stratification criteria could not predict the SCD or the activation of ICDs. Essentially, in 2018, there was a postulate
во время
put forth that the induction of VT or VF in the course of EPS is the most accurate predictor, is the most accurate marker for ventricular arrhythmias emerging later on, compared to commonly accepted criteria. This helps us conclude today that EPS, endocardial electrophysiological study, is expedient to assess the SCD risk in patients with HCM. On 2B class recommendations to implant an ICD, meaning that these are patients with only one risk factor for sudden cardiac death. Patients in the so-called gray zone, where we are unable to determine whether a defibrillator is necessary or not. Essentially, all we have is the diagnosis of HCM. The second part of my presentation will focus on the importance of EPS for patients with atrial fibrillation and hypertrophic cardiomyopathy. A clinical example at once to go with it. Let's say young male, 33 years old. Diagnosis of HCM was established in 2014 at the age of 29. Apical hypertrophy of 23 millimeters, 2 episodes of heartbeats, a history of 2 episodes of heartbeats. After monitoring 5,200 of extrasystole, ventricular extrasystole, physical exercise test, no hypotensive response.
И для того, чтобы принять решение о
To make a decision about risk stratification for this patient, the patient received various trials, various tests. Endo-EPS, no ventricular tachycardia induction. However, in programmed atrial stimulation with proper HRA delays. In the right appendage, we've seen episodes of fibrillation, of atrial fibrillation, that the patient admitted to having before. They were not seen in Holter monitorings before. And these episodes were stereotypical at the same delay length. We went for radiofrequency ablation of the right atrium. You see the reconstruction. Central isolation was performed. Modification of substrate on the posterior wall, on the distal wall, sorry. The atrium. The patient was discharged, and at control follow-up 9 months after RFA, there were no pathological heartbeats that were seen before. We canceled antiarrhythmics and NOACs. The patient is on bisoprolol, 100 milligrams. Further on, when we did cardiac MRI and we saw fibrosis over 20%, we implanted subcutaneous ICD into this patient. I will not talk about that. The S-ICDs is a topic of the following presentation. It will be dedicated to this topic, so I'll just skip that. It's an interesting fact that back in the 80s, when the first works for EPS in patients with HCM and supraventricular tachyarrhythmias was seen quite often back then. Covey showed that 2 patients out of 7, the SVTs could be induced. A later trial of 1992 showed that this EPS caused the following frequency of onset. So how often is AF seen in HCM? This is the data of 2017 that showed out of 20% of patients with hypertrophic cardiomyopathy, there were episodes of atrial fibrillation. This is the breakdown for paroxysmal, 3/4, and 26% were persistent form of atrial fibrillation. It normally develops after 6 to 7 episodes of paroxysmal AF. Atrial fibrillation in these patients presents earlier, 10 earlier before than overall in the general population. Also, the thromboembolic complications there's a high risk for those, 0.8% per annum. Patients with HCM and AF. Endo-EPS for patients with HCM to establish the accurate diagnosis can be justified by the fact that we often require precise diagnosis. In case of broad QRS complex tachycardia, tachycardias WPW syndrome, verification of fibrillation and atrial flutter, especially in the age of RFA for AF. As for the radiofrequency ablation in patients with HCM,
то данные группы Джозефсона,
the research of Josephson's trial group
Многочисленные
published in
работы,
2015, as well as numerous works that followed,
проведенный метаанализ свидетельствует,
including the meta-analyses that were carried out based on them, involving them, suggest that patients with HCM and AF, radiofrequency ablation
демонстрируют более
is
худшие результаты по сравнению с
statistically significantly worse. It's inferior to the patients without this diagnosis, with AF without HCM. What is the cause of that? The authors explain the reason of a relatively low efficacy of RFA in patients with HCM and AF because of the morphological changes in this category of patients. Back in 2003, it was indicated, it was shown that the pulmonary vein isolation
и восстановление приводит, как правило, к восстановлению проведения в этих
normally restores the conductivity of these pulmonary veins 5 months on. At the same time, the conduction recurrence is not always correlated with recurrences of atrial fibrillation. Out of 17 patients after primary RFA, pulmonary vein isolation, 14 cases out of 17 sinus rhythm was restored, no AF or no abnormal beats. No recurrence of AF in the majority of patients, therefore. This fact is interesting in that it's not just the pulmonary vein isolation that will contribute to the clinical effect of AF treatment, including the patients with hypertrophic cardiomyopathy. In this respect, I would like to show you the second clinical case. This is a patient.
Сегодня даже я увидел его данные МРТ сердца. Это первый ее клинический пример. Это пациент с отрицательным фенотипом.
Lady, 40 years old.
Рождение, мужчина.
It's a male, 40 years old. So I've seen the cardiac imagery. He received an ICD in February this year for primary prevention of SCD. Later on, the patient presented with persistent AF. Cardaron therapy contributed to thyrotoxicosis. In March this year, he received an RFA as antiarrhythmic pre-medication with dronedarone plus anticoagulants. Alexei was supposed to join me. I'm not sure if he's there. This is my last case.
Согласится ответить на некоторые вопросы.
He will be willing to answer your questions if you want.
Да, спасибо большое, Евгений Геннадьевич. Алексей Николаевич, вы слышите меня?
Да, добрый день.
Алексей Николаевич, рад вас видеть. Сколько у нас уже прошло времени после сессии?
How much time has passed after our RFA session? I'm on month 8. How are you feeling? What are your impressions? What can you say?
Ну, по большому счету,
My impressions are as follows. Basically, I started living my life again properly. After the improvement of the rhythm, when my heart rhythm was broken, I was lying down. I was a disabled person, essentially. I couldn't walk, I couldn't breathe properly. It was a shortness of breath. I couldn't.
Собственно, я обрел новую жизнь. Спасибо
вам. After the surgery, I started living my life again. Thank you very much for doing that, because without cardiac rhythm, I simply saw no ways to exist.
Работаю, путешествую, сам вожу машину.
I'm driving myself. So basically, I came back to normal life. I feel myself a full-fledged member of the society, as a healthy person. Do you still take dronedarone and blood thinners? Yes, the blood thinners, dronedarone, I'm on that, I'm on those. Yes, everything as prescribed.
Евгений Геннадьевич, а у вас есть возможность презентации операционной комментарии по размеру левого?
Operation stages and
Я левое предсердие не могу, у меня не
left atrium. Unfortunately, I can't. That link didn't open.
Светлана Александровна отметила,
Well, Svetlana also pointed this out. And the sound is distorted.
2018 года, и операционный этап показал, ну, наверное, это самый большой
The
прецедент.
operating stage showed probably this was the largest atrium, 340 milliliters, the right atrium cavity volume.
И хороший результат спустя,
The
получается,
left atrium.
9 месяцев.
Okay, good result, 8 months, 9 months after on. After that, how much time? 8 months. Controlled interrogation of the device. 1 month again, 1 month back, no persistent arrhythmias, no bad stuff. Do you have questions to Evgeny or our
Наверное,
patient?
пока нет.
No, I don't. I don't have at this point.
Спасибо большое. Спасибо большое.
Okay, thank you very much. Then, thank you, Evgeny. Thank you, Alexei, for finding the time to join us and present your experience. Hope to see you again sometime. Thank you.
Мы
Thank you, esteemed colleagues. We are moving forward to our final presentation of the day. It will be dedicated to the prevention of SCD. This is an enormous task. As you understand, it is resolved most efficiently within primary prevention framework. When we're working with the secondary prevention, as you know, the existing statistics is basically not that optimistic. We'll be able to help only 2 people. So primary prevention is the other way around. So it's not 2 out of 10 patients that we can help. For primary prevention, we will be able to efficiently prevent the sudden cardiac death in 8 cases out of 10. 80% prevention success, primary prevention. That's an enormous figure. Luckily, the defibrillation methods, including implantable defibrillation, are improving as we speak. The subcutaneous, completely subcutaneous ICD methodology is widely spread in patients with HCM. We have Olga Kosteleva reporting that. Doctor, the floor is yours. Good afternoon, dear colleagues. It's a pleasure to have been granted this time slot to talk about new approaches to SCD prevention in patients with hypertrophic cardiomyopathy. Luckily or unfortunately, my previous colleagues made a big emphasis on the problem itself. Because of the time limit, I will skip some of the points. I will not talk about them in details. I will simply focus on the points that are interesting from the viewpoint of my topic. Hypertrophic cardiomyopathy is frequently seen in younger patients under 35. It can also be manifested in any disease progression type, HCM, and without prior symptoms. An important fact for us is that the SCD in HCM is mostly life-threatening ventricular rhythm disorders or rhythm disturbances. Although there are some ready rhythm disorders, the role of ICDs is well studied today. This is a golden standard of secondary prevention of SCDs, of all cases of sudden cardiac death, of all reasons of sudden cardiac death. The implantation of ICD is also grade 1B recommendation class, because these are the patients with a history of cardiac arrest. What we should be looking at is that whether we can help prevent the cardiac arrest in the first place, whether we can help patients avoid that. It so happened that the MADIT-2 study that you know for ischemic cardiomyopathy, they started in the mid-90s. By 2001, there was a clear concept that took shape of the primary prevention of sudden cardiac death. HCM was a bit late to that show, virtually a 20-year delay. In the year 2000, применение the year 2000 was when the publication was first featured to show ICD as an efficient way to prevent life-threatening arrhythmias in HCM patients. As you can see, the mortality of patients with HCM was reduced from 60.5% because of ICD.
Спасти одну жизнь, она составляет 6 к 1.
6 to 1 is the ratio of patients, 6 patients with implanted ICD will save one life.
Используется для
Same way
лечения
for the same statistics as ICDs to treat sudden cardiac death in the general population.
Наверное, особое заболевание.
It's interesting that HCM is a special disease with a rare transformation of HCM into heart failure, progressing heart failure, which helps use the ICD therapy for a long time as life-saving therapy. For this reason, we need to clearly understand that primary prevention of sudden cardiac death is the pillar, is the cornerstone for patients with HCM at the current stage of development. Several times, risk stratification was brought up today. Nonetheless, the identification of patients with high risk of SCD is a main challenge, is a huge challenge, as I'm sure you will agree. And there are many unresolved issues that might help us detect the patients to receive ICDs who will benefit from these devices. According to any directive out there, any guideline out there in the world, it was also mentioned multiple times, the risk stratification at primary and follow-up examinations must be done. Since HCM is not a static disease, every guideline suggests reassessment of the SCD risk every 1 to 2 years, or in case there are changes in the clinical status. The speaker before me, Evgeny Zhidakov, said that risk stratification can be done according to 2 models, the American and the European model. We've been taught to use the risk calculator put forward by the European Society of Cardiology. There's one downside I can admit. This scale does not apply to children and to patients over 80. However, it's quite useful because when we put in certain characteristics, certain patient parameters, we can calculate the SCD risk at 5 years. Now, this scale basically was featured in ESC 2014 guidelines, and it was also introduced in the Russian guidelines of 2017. However, you can see that there are no grade 1 evidence. The evidence grade is 2 at best. Clinical guidelines for HCM that were published this year will have another line. The previous recommendations only had 2 lines, class 2A and 2B grade, evidence grade. And there is a third line in the new guidelines that basically translates the recommendations of 2014. We can consider the implantation of ICD in certain patients with a risk score under 4, in case there are proven prognostic characteristics that justify that. Last week there was a conference where I got a question about the role of genetic features or genetic parameters when determining the risks of sudden cardiac death. Wonderful presentations on that have been voiced before me, and I believe that if the presenters wish, they will focus their attention on further guidelines, on further potential recommendations as to how this can be taken into account. As far as I have understood, or as far as I know from the literature data, there is no evidence database to suggest or to determine specific patients with genetic changes and mark them with a risk for sudden cardiac death.
Представляется возможно вам показать.
Something I see possible to show you today, for those of you who practice in healthcare, you select patients.
В этих же клинических рекомендациях появилась
These guidelines on HCM now have a very easy to use table, a very to use pathway to detect patients, potential candidates for ICD implantation. As you can see, it's quite easy to understand, quite concise. All the features are located here. The clinical guidelines also include something that's not been properly publicized. Every speaker today talked about this. If there is an MRI test that can be used, we can use the MRI test data to identify the risk group of high sudden cardiac death. And these patients can be recommended for ICD implantation. As opposed to traditional cardiomyopathy, HCM has no randomized prospective clinical trials to see the benefit of use of ICD for primary prevention of SCD. So these kind of trials are necessary to look into the experience of the use of these devices. However, nonetheless, as I have mentioned, the implantation of ICDs, cardioverter defibrillators, has become the standard treatment for patients with high risk of sudden cardiac death, including patients with HCM. Since the era of ICDs started in 1980, now we're looking at the end of the fourth decade of ICD therapy. Nobody doubts the efficiency, the efficacy of the use of ICD. They're highly efficient. However, everybody knows that despite huge upsides, the implantation of transvenous TV ICDs comes with certain complications. The main ones are presented in this slide. Intra-op complications, post-op complications, and quite severe ones at that. And most importantly, since the leads are the Achilles foot of every stimulation device, the damage of the leads can cause inadequate shocks. And we know what it might result in. The psycho-emotional and physical state of the patients can be damaged severely because of those inadequate shocks through lead defects. There are issues of the vascular flow, obliteration, thrombosis because of indwelling TV ICDs. This is definitely a small downside to all the benefits that they bring. Why is it important when we're talking about patients with HCM? As I mentioned in my first slide, these are younger patients, and these are patients that will outlive or that will see many changes of ICD systems. These are active patients that have higher risks of lead damage and inadequate shocks as a result. 2017 saw a paper published that showed the frequency of inadequate shocks in HCM patients can reach as high as 5% of patients per annum. In high percentage of cases, patients with HCM do receive an ICD for primary SCD prevention. So this aspect is highly significant to us for that reason. And since these patients live long enough to experience multiple surgeries, well, they need a longer protection against sudden cardiac death. The life expectancy is higher. You know the evolution of these devices. It started with major abdominal ICD implantation. The devices were on the one on the abdomen. Transvenous access was better because the risks went down, but as I've shown, they didn't go away completely. there are still serious risks remaining. So patients with HCM, in 2002, there was a concept to use subcutaneous ICD to exclude, to eliminate life-threatening arrhythmias. And this direction this direction looks quite promising when using in patients with hypertrophic cardiomyopathy, because A, these are young patients, they are active, B and C, they suffer the higher risk if implanted a TB ICD. This slide shows conceptual differences of a TB ICD and subcutaneous one. Transvenous involves the vessel flow, the electrode, the lead, goes into the heart cavity. Subcutaneous is different. The lead is under the skin, subcutaneous. It goes along the edge of the sternum. It's untouched methodology. The vascular flow is not affected. And this device is placed also under the skin. I'll talk about the changes in the methodology. The methodology has progressed. Now we're using intramuscular access. The lead is conceptually different from the one used in TB ICDs. There's no cavities. For this reason, that lead in S-ICDs is capable of handling severe stresses, including CPR. What is an ICD, an S-ICD today? Good or bad, we're sometimes running late. We're mostly running late. But luckily, there is a Generation 3 device available in Russia. It evolved throughout its lifespan. Of course, it's bigger than transvenous, but if we recall the first TB ICDs or the first abdominal devices, you will know that this device is much smaller than those. It's a modern device, which is very important for our patients, young patients with HCM. What's important for them, I mean, is the devices do not limit MRI, do not limit the zones or areas of the timing of MRI, the time frame of MRI, which is, well, full body scan is possible if these are implanted. What can these modern S-ICDs do? First of all, they only defibrillate. They only do shocks that are not programmed, and its power can reach 80 joules. Why the high energy? The transvenous are 41, limited at 41. Well, in this case, the shock must go through the sternum or through the thorax. 5 shocks per episode. No Brady stimulation at this stage. This is one of the big downsides. So we immediately categorize patients that must not have this device. Brady stimulation is not available. ATS is not there, so patients with monomorphic ventricular tachycardia are not a fit for this device. So very rapid ventricular tachycardias that cause rapid loss of hemodynamics. Post-shock stimulation is brief, 30 seconds after the shock. However, this device is a smart one. We can program 2 areas or 2 zones, which helps, and I'll elaborate on that later, which helps employ the risk discrimination algorithms. And since today we've been talking about patients with HCM, they have a problem with ventricular defibrillation. You might find it optimistic, and the last device, or the most recent device available in the Russian market, comes with an AF monitor function. It helps diagnose and detect atrial fibrillation episodes. For patients with hypertrophic cardiomyopathy, this is definitely a good benefit, a big benefit for them. Our rhythm discrimination algorithm is conceptually different from the TB ICD. There are 3 stages of the analysis. The work has been done that was called START, a paper published. You can read that paper. It's a decent research that I like. It's a head-to-head comparison, basically. It can be referred to as one. Sensitivity and specificity in an S-ICD was very, very high, 100% sensitivity, 98 specificity. HCM or not, the Praetorian trial that was published this year and reported at the online session.
Наличие дискриминационных алгоритмов, оно приводит к тому, что у подкожных
Discrimination algorithm analysis show that S-ICD have no problem with detecting, or they have fewer problems than TB-ICD on this parameter. This might also be a benefit for patients with HCM. For this reason, out of everything I said, from everything I said, this is a system that does not involve the vascular bed, the bloodstream. It reduces the risk of intra and post-op complications. Again, it preserves the vascular bed in case transvenous device will have to be implanted at a later stage. It's easier removal, easier replacement. We have fewer complications of infectious nature because of less intervention. Potential problems that stay. It's potential risk of inadequate shocks. T-wave interpretation literature says that, but we'll talk about it, that this problem is successfully resolved. And also there is a lack of bradycardic support. Many trials have been performed. I did not cite them in this specific session, in this specific report, because they were mostly valid for all the population group that used an S-ICD. High efficacy was proven for detection and elimination of induced tachyarrhythmias. The frequency of inadequate shocks corresponds to the frequency shocks in other types of ICDs. The frequency of inadequate shocks in patients with HCM is basically the same as inadequate shocks in other types of CM. In patients with HCM, the main reason for inadequate shocks is the perception of ORS T wave. Why am I highlighting literature sources here? Because articles come up every year. This year there have been some, last year there have been some, but a large cohort of patients that were featured in those, that were enrolled in those studies, they had Gen 1 and Gen 2 devices, whether we have a Generation 3 device these days. The previous generations did not have some incorporated functions that I will talk about a bit later. The downside is a lack of bradycardic support. Nonetheless, ESC guidelines of 2015 started featuring subcutaneous ICD as an alternative to transvenous defibrillator. 2017, the same guidelines were embedded into the Russian guidelines, although by then there were no available S-ICDs in the Russian market. 2017, American Association guidelines, S-ICD was also, they also recommended the implantation of an S-ICD, evidence grade 1. The same will happen in our Russian guidelines, because this year we started clinical approbation and the implantation of subcutaneous ICD, enrolling 150 patients into that trial in the course of 2 years. Mostly the Moscow-based and St. Petersburg clinics are involved in this approbation program, as well as Novosibirsk, plus small numbers to be implanted in Ufa and Volgograd. For this reason, I believe that S-ICD is coming into our objective reality rather than some abstract future that we talked last year without having anything to show for it. For all of us, the result of the first randomized trial are important. That's dedicated to S-ICDs. It was published in New England Journal of Medicine this year. The Praetorian trial showed that subcutaneous ICDs are not non-inferior to TB ICDs with respect to complications induced by an ICD. This trial will be ongoing. It is designed to show the advantages of S-ICDs compared to transvenous ones. A subcutaneous device is conceptually different from transvenous by way of different technique of measuring heart signals, not from within, but from the outside. This is a proven theory, the concept of 2021, how the system is supposed to be located. 3 vectors field perceived by the device. And it's important for us preoperatively to understand that the device will see all these signals in the implanted system. Currently, there is a certain role, and we do that for everyone. There is a screening possible, based on which we will determine whether the patient is a good or a bad fit for implanting an S-ICD. Hypertrophic cardiomyopathy patients, well, in this light, it's of even more significance, because patients with HCM, as you have mentioned, come with many structural abnormalities that are not static in their lifetime. The literature data, again, you can see how many patients were not screened. These days, again, the literature sources suggest a lower number, but still a number of patients are not screened, a number of HCM patients are not screened, regardless of the presence of indications to implant an S-ICD. The screening basically involves the assessment of EKGs and standard leads. It was originally assessed using a special screening ruler, and I believe that in the majority of articles where screening was used, this approach was actually employed. It's manual determination of a go or no go for an ICD to a specific patient. However, these days we have an automatic screening tool that essentially resolves a big number of issues. This device analyzes the EKG automatically, and it shows us the interpreted results already, ready to use results. Therefore, I believe that automatic screening tool helps us recruit more patients eligible for an S-ICD implantation. Unfortunately, some patients do not pass the screening. And again, looking at the published data, we see that the majority of researchers recommend that patients with hypertrophic cardiomyopathy to have 2 suitable vectors, supine position and at least one position standing up or sitting down. Because again, over time, certain parameters, the progression of the disease itself might change. Certain changes can result. So patients with HCM 2 vectors should be used in patients with HCM, although only one is recommended for others. Maybe this is why HCM patients are unable to complete the screening. This is the work of 2020 that showed the improvement of the potential ways to improve the screening process. The patient recruitment started earlier when the screening was manual, and as you can see, the contemporary device features an AST program, incorporated parameters and incorporated program features, software features to see or to run the screening on the left-hand side and right-hand side. Our methodology involves placement dorsally, closer to the back. The screening of exercise test. A number of authors still recommend this with that objective, to project or to forecast the potential frequency of bundle blockade and take that into account when optimizing the vectors. I've mentioned the oversensing problem. The developer company found a way to resolve these issues. In 2014, there was an additional algorithm added on top. In 2016, the 2014 received alternating morphology analysis. It did not resolve all the questions, all the issues. SmartPass was introduced in 2016. That helps discard the T wave. And that novelty helped reduce the number of inadequate shocks throughout the year. This year, the untouched trial was reported. The number of inadequate shocks related to T wave, or T wave related inadequate shocks, was markedly lower than in transvenous systems. I should say that yes, this is a general population, not HCM patients, but I believe these results can be extrapolated also on HCM patients. These days, we're supposed to do a post-op loading test, and again to assess the potential risks for to analyze the T oversensing at high frequencies or the frequency-dependent His bundled blockade. This is all done, properly done, successfully done. I should also highlight the fact that these days patients with HCM, and not just them, all the patients with subcutaneous ICDs receive the induction test, which is not used in transvenous systems. Although, again, the literature data suggests that in HCM, it is desired to do an induction test also when transvenous systems are implanted, because they might require higher stimulation periods. The most recent publication, this year's publication, it featured the SmartPass patients. The number of inadequate shocks is fairly small, down to 3.8 per annum. In primary prevention, it's properly eliminated. No inappropriate shocks, whereas patients with secondary prevention, they had, well, there were patients with atrial fibrillation as well. In this case, given the features of the device, they can be adjusted. There is an algorithm to manage inadequate shocks, patients with inadequate cardiomyopathy that are successfully used in our practice. In this case, I'm citing the summary of these guidelines to reduce inadequate shocks, inappropriate shocks. And again, the SmartPass algorithm incorporated in contemporary S-ICDs helps handle these adverse consequences. Our experience is very limited these days. As few as 35 devices have been implanted in all of Russia, 2 patients with HCM and the S-ICD. The follow-up time, 2 years and 3 months, and 1 year, 2 months. No inadequate shocks in 1 patient, 1 inadequate inappropriate shock in early post-op period because of the air that remained in the wound. So far, we're looking at 2 similar vectors. Only 1 was performed, the alternate vector, and we decided not to take risks. The methodology today involves intramuscular placement of the device or between the muscles. This is how it looks on X-rays. Dorsal placement closer to the back, which basically is more reliable. This is the first student, obviously not my picture, the patient with generation 1. This is our patient in 1 month after implantation, and a lady, both are aged 33, 6 months after the surgery, after the implantation. Not one of them complains of any cosmetic problems. They live a happy life as such. This is the evolution of this S-ICD therapy. This methodology evolved along this path. In the near future, it is expected that the S-ICD will be incorporated in the so-called pacemaker needle and will be able to resolve bradycardia in patients, bradycardia issue in patients. That's it. That's everything I had to show to you with respect to potential use of S-ICDs in patients with hypertrophic cardiomyopathy. If you have patients like that and you wish to refer them for potential placement of a subcutaneous ICD, please feel free to reach out to us. Mostly, again, it's most Moscow-based and St. Petersburg-based clinics. They will happily receive these patients and help them. Thank you so much for your attention. You can hear me, right?
Спасибо большое, глубоко уважаемая Ольга
Yes, thank you
Валерьевна.
very much, esteemed Olga, for this comprehensive presentation on your topic. Esteemed colleagues, we are now completing our today's webinar. Are there any questions to the presenters? If there are, please publish them or type them into the chat box to our today's event. We will definitely pass them on. We will provide the answers. And as a rule, our previous conferences, similar conferences, showed fairly high interest to our previous webinars. Hopefully, this one will also enjoy popularity at a later stage. Once again, we are prepared to take your questions. As a conclusion, a few words from my side. I believe for those who joined us and our future audience that will watch the recording of this webinar, it's obvious that hypertrophic cardiomyopathy is an immense problem. Talking about the primary feature of this issue, I would formulate it in one word: underestimated, underrated. Possibly, we fail to understand actually what is the prevalence of this disease, what the prevalence of this disease is. We have clear clinical criteria. We have an objective picture, objective definition of what HCM is. Nonetheless, in our day-to-day routine practice, a GP and a cardiologist, oftentimes, when they face these patients, they might have problems. Right. And it will contribute to genetic research, proper genetic research, adequate risk stratification, and risk of sudden cardiac death. Obviously, the clinical picture, patient with hypertrophic cardiomyopathy, today, in COVID pandemic, it's also undergoing changes. Traditionally, it is believed that these are patients aged 55-ish. And this age is believed to be the most frequent age of onset of HCM or detection of HCM. Even these days, in the course of some reports, you've seen that some of these patients are much younger than that. And the issue is that there are not just risks of sudden cardiac death that haunt these patients. The phenotype of this disease could feature predominantly the diastolic dysfunction. Atrial fibrillation, stroke prevention is a big issue. Prevention of AF and stroke. Again, this term or this word, underestimated, underrated, is very topical these days. Oftentimes, young patients with left ventricle hypertrophy receive no adequate diagnostic support nor adequate therapy. So please make sure you remember that. Anything else coming up today? Right. So, dear colleagues, we would thereby complete our today's conference. Are there any questions among the speakers? If you don't mind, I will give the floor to our esteemed colleagues. Maybe they can say a few words about the course of today's webinar, exchange opinions. If you want to take the floor, Svetlana, you now have the floor to complete today's event. Good afternoon once again. Andrei, again, I appreciate very much the invitation to participate in this conference. I fully agree with you that a major cohort of patients with hypertrophic cardiomyopathy, it will go unevaluated with classical means of diagnostics. Also, many patients most likely presenting with some minor markers of myocardial changes, HCM will not develop, at least at the time when they end up in the cardiologist's room. The true HCM will not prevail. And mostly these patients will suffer from atrial fibrillation. Later on, this patient may be missed by the cardiologist, left out of this follow-up paradigm, and the true diagnosis will never be established. However, for this reason, I encourage further use of new visualization imaging techniques, especially in patients or even in patients with minor developmental disorders. There are more and more opportunities in our country and worldwide to use these techniques. Thank you very much for the invitation. Thank you. Yes, I completely agree with you. The imaging methods for myocardium definitely truly expand our diagnostic capacity. And again, whether we like it or not, we can reconsider, we have to reconsider the HCM patients, how we approach them. MRI is definitely necessary as an imaging technique. It's the cornerstone element. Natalia, a few words, if you will. Dear Andrei, I would like to thank you for the invitation to this symposium and to thank you for this whole symposium, which I find meaningful and well-structured. You have indeed been able to
важным гипертрофической кардиомиопатии от классификации
HCM, starting from classification, etiology, diagnostic methods, and
замечательно и в целом и
It's been wonderful.
с огромным количеством информации и с акцентом
на lot of information, data geared towards practicing cardiologists. I believe that this symposium had to happen, and it did. You are completely right saying that this problem is underdiagnosed, underrated.
Может быть, обучать врачей.
We should definitely start teaching, educating doctors, running the similar symposia, showing the clinical cases as demonstrated, and talk about not just genetic diagnostics, which is not the core
то, что сказал профессор Маккенна, что очень важно начинать с ЭКГ.
Professor McKenna said that ECG must be started. That's where we should start. MRI, because I know that many patients turn in for follow-up. Fewer than 50% of these patients receive an MRI ultimately as an examination routine. Stress testing, ECG, other diagnostic methods should also be involved. On top of the genetic diagnostic. Genetic diagnostics can serve to confirm, but not at the initial stage. And definitely, practicing clinicians must also be educated about this problem, so that they remember about this, especially in the light of emergence of new products that can contribute to better management of HCM. Thank you so much for this wonderful symposium. Thank you, esteemed Natalia, for your high assessment of the work we do. Once again, I would like to highlight the attention of all our colleagues on the phenotypical form of hypertrophic cardiomyopathy that I believe we will still face in the future, will still meet in the future. This is a truly phenotypic option of cardiomyopathy that is definitely underrated. Let's refer to it as such. It's number one, HCM, sudden cardiac death. These patients simply fail to reach us alive. And in this case, true prevalence of HCM, and again, for many years to come, for decades to come, possibly, it will just become a thing in itself. It will be a truly underestimated problem. The new methodologies of diagnostics help us adequately help these patients, new methods of treatment. And Olga, now would be the time to give you the floor to complete our today's conference. Well, dear colleagues, thank you very much. Well, I would really like to talk about this by the prominent figures in HCM. I would encourage them to voice their opinion about S-ICDs, especially those living outside of Russia, because foreign nations have been using this S-ICDs for a longer time. There are clearer results. I believe that the emergence of S-ICDs in our country's market will help resolve the issue of prevention of sudden cardiac death of young people. They will simply agree to these surgeries more often, more frequently, especially if the doctor does talk to them in accordance with all the international requirements and standards. For this reason, I would like to hear what my colleagues have to say rather than speak about it myself. Thank you, Olga. Unfortunately, that's the last people standing, 3 people only available to contribute that opinion. So in this case, me as a person that does have some relation to the phase 0 study of S-ICD, indeed, back in the year 2000, we were honored to be part of that phase 0 project. The configuration and the geometry of leads was determined. Various options of subcutaneous tunneling placement were analyzed, and the image and the presentation of the device that exists today, its appearance, its placement, they were handled in Moscow in the year 2000, 2001. So Moscow does have a certain relationship, or does have something to do with this methodology from its ideation. Patients with idiopathic HCM, and most likely it's a big number of patients, underestimated patients, young patients, physically active ones, most likely it is for them that the chronotropic support will not be relevant. For this category, decompensation of heart failure will also not be the issue. Most cases, it will be too early to speak about that. They are active, their lifestyle is adequate, but nonetheless, visualization, imaging techniques, genetics, clinical rigor will help us detect these diseases earlier. And hopefully primary prevention without the leads in the heart is also going to be there. HCM is the category of patients where S-ICD is the most adequate option, if not to say the method of choice for primary prevention of SCD. The data is well known. A huge cohort of patients today in Europe, North America, they receive this type of help. Patients with hypertrophic cardiomyopathy, including those for primary prevention. The criteria, as you know, in the scope of attention, they are the scope of attention. However, you've heard how MRI can be used with late gadolinium enhancement, prognostic importance, quantitative assessment of fibrotic degenerations of myocardium in the ventricles is one of the key criteria that helps decide and helps discuss broad implementation, broad introduction of primary prevention of SCD. even now, especially now in the COVID pandemic time, we see the moderate to severe course of COVID with moderate to severe involvement of lungs, and still patients come with atrial fibrillation, with total damage to the left ventricle, with compromised contractile function of the LVEF reduced. Essentially, these are the patients that require prevention, including the SCD prevention these days. I believe that this issue will gain relevance over time, including the subcutaneous methodology. It will be subcutaneous ICDs will become an important way to resolve this issue. So, being the host, I would like to complete this conference. I thank you very much indeed, dear ladies, dear colleagues, for your resilience. Time and time again, I see that women are indeed the strongest sex, the most reliable colleagues, comrades. So thank you very much for being here. I thank you for your support, and please rest assured that you can hope for my assistance if ever you need that. So have a good evening, all of you, the close ones, all of our colleagues that have been with us today. And I hope that the dynamics of our conferences will be preserved and maintained in the future. Now, later on, we'll also meet each other. I would like to extend you an invitation. The previous meetings are available already. 1,000 views per month. That's the kind of parameters that we have for the webinars that we run. Hopefully, this dynamics will continue in the future. Thank you very much, everyone. Have a nice day, everyone. Thank you.